All right. Good morning. Hold on, guys. Sorry. I know I'm making all kinds of noise with the microphone here. Give me just a second. Okay. Good morning. Only 2 classes left after today. So we have Monday and Wednesday of last week. We're going to learn some skills today, but there's only one more skills day after today. So Monday is our last skills day. So Wednesday, we go over things after certification. We talk about how to find a job, how to interview, how to renew your certification, how to get your continuing education, how to figure out which workplace is right for you. We got a lot of stuff to cover on that last day of class. So still a lot to go, but we're getting close to the end of our time together. All right, so over between last class and today, you had chapter 7, which was a skills chapter. Let me get your scores, and then I'm going to open it up for questions. I know we've got a few. Victoria, how did you do on chapter 7? Thank you. Tempest. Jaylind. Thank you. Serena. Brigitte. Monica.
I missed one.
Thank you. Monica, do you have 5 and 6 for me?
Oh, yeah. I missed one on each one of those. As well.
Okay. Kaya? Thank you. Arjola? Thank you. Ito? Ito, I need from you, I don't know.
I did them too. I got 100 on the last one.
Okay. All right. Thank you. Not sure how I missed those. Sorry. Bobby? 95. Jayothi? Deja? Okay. Does anybody have any questions? Yes.
Really quick. Unit 4, show us what you know. You are performing hand and nail care on one hand for the care plan when the patient asks, why are you not washing her other hand? What is the appropriate response?
Okay.
It's throwing me off. I know it, but I'm questioning. I know it's not B and C, which is, that's none of your business, or how am I supposed to know I'm just a CNA? But A is, I'm not really sure. The care plan told me to wash your right hand only. I can get the nurse for you if you would like to know more, which I'm pretty sure that's the answer.
Okay.
And the other one was like, you are scheduled to have an ABG in your left wrist later this morning, and soap may interfere with the pH levels in the blood because as needles enter your skin, soap residue can contaminate it.
Okay.
So, I know. I'm thinking that's what a nurse would explain to the patient, and we don't explain.
Correct.
Okay.
Correct. So that's a communication question. And we know that because the question asks best response. Okay.
Right.
Or what would you say? So anything that says best response or what would you say or how would you respond or that's a communication question, right? Communication questions always have an option that is absolutely roll your eyes, not allowed. You can just throw that out. But there's usually 3 responses that are a little bit less obvious. So you have to use a little logic here with communication questions. The first thing that you want to look for is any response from you that treats an adult like a child. And you will see these, right? So these are adults. Even adults with dementia are still adults, okay? So we have to be really, really careful. We don't treat adults like children ever. I know you see it on social media all the time. So we kind of becoming deconditioned to this. And that's a really, really bad thing. Adults need to be treated with respect, with empathy. We never use words. There are elimination words. Never use words like force or restrict or punish. Be very careful there, right? So you don't want to use any responses that lead you in any of those directions. So you can usually get rid of the one that's like roll your eyes stupid. You can get rid of the one that treats an adult like a child. And then you're usually left with 2. One of those often is outside of your scope of practice. And that's actually what that answer is testing you on. Are you going to pick a response that is outside of your scope of practice? And then the other one may not be the way that you would phrase something, because we all have different speech patterns. We all have different ways of communicating. So we're not picking a response based on this is exactly what I would say. We're picking a response for the test based on, yeah, that one is just stupid. That one, it treats an adult like a child. And that one, not in my scope of practice. So this is what's left. This is the one I probably should pick. So communication questions on the exam are tricky because you're probably, honestly, not going to respond in a clinical setting the way that this question or this response is worded. Does that make sense? But there are a few keys that you can use for this. If there's something called therapeutic communication. Now, therapeutic communication is a way of relating to other people using open-ended communication. We often try to shut people down. Okay, we don't want them to talk. We want to go in, get our job done, and get out. So our default is to do yes/no questions, because the less we have to talk to the patient, the happier we are. Yes/no questions. That does not encourage conversation. It does not encourage expression. Those actually should never, ever be picked. We want to look for things that encourage expression, but we also want to look for answers that reflect back to the patient what they just said. So if your patient says, nobody loves me anymore, your response to that should be, it sounds like you're feeling lonely. I'm reflecting back what the patient is saying, and it gives them an opportunity to either expand on that or to correct my assumption. No, I'm not saying that, that I'm lonely. I'm saying that everybody's dead. Nobody loves me anymore, right? But it gives them an opportunity to express. Now, if I said something that was dismissive, like, don't say that, what does that tell the patient? What am I expressing to the patient when I say, don't say things like that? Right. I don't want to be involved in this. So I want you to think about you for a second, because we don't really think of patients as real people. We just don't. We think of them as something we have to do. We don't think of them as real people. How many of you guys have a best friend? How many of you have a significant other that you tell everything to? Okay. So if your significant other is your best friend, you have somebody to talk to. How many of you bounce your ideas and your thought processes and your emotions off of your support person? Okay. I want you to understand that in a clinical setting, these people do not have their support person. So where are they going to get support? It has to be from us. And when you back away from that, when you tell the patient, don't say things like that, or you're very dismissive, or I'm sure your family's just busy, or you shut them down, you tell them, I don't care about your emotional state, not my problem. Now, imagine you going home today and trying to talk to your significant other, and that's the attitude you get. I don't care about your emotional state, not my problem. You'd probably feel very isolated. And isolated people tend to act out. Communication is a really big deal in healthcare. Now, the answers that you see on the test may not be exactly the way you speak, but you do need to learn therapeutic communication. You do need to learn how to reflect back to your patients. You do need to learn how to acknowledge their feelings, how to support them emotionally, how to encourage them to talk. That's not just an exercise for the written test. That's something you really should be doing because you are going to be the support system for these individuals. And I don't think we talk enough about that in training. I think that emotional support is just as important as physical support. You know, there's a saying that I heard a long time ago, people don't care how much you know until they know how much you care. You can give the best bed bath in the entire world. But if you treat the patient like crap and they feel that you're treating them like crap when you're performing that bed bath, are they going to perceive that as a good technical bed bath? No. And let me prove this to you. Now, we're not going to say names, okay? I want to preface this by saying we're not going to say names. But do you have a specific healthcare place that you will not go to, like a hospital? Anybody have a specific healthcare place that you absolutely will not go to? Okay, but you have a strong opinion about a specific healthcare place, right? Let me bring this to your attention. All right, let me explain this to you. Let's just say that I don't like hospital ABC. Am I talking about the color of the building if I tell you, oh my gosh, don't go to hospital ABC? Am I talking about their landscaping? Am I talking about the x-ray that I had done? Who am I talking about? The people, the way that you were treated. That forms the basis of your entire impression of that facility. Now, chances are those people that you had a problem with probably aren't even still there anymore because healthcare is very transient. People only stay at a place for a year or so and then they move on to get a higher wage somewhere else. So chances are you're saying, I'm never going to go to ABC Hospital, and the person that you had a problem with probably isn't even there. Even if you went, you probably wouldn't have any interaction with that person because it's not usually everybody that you encountered. It's usually one or two individuals. So one or two individuals out of the 1,000 that works at that facility made you make a decision to never step foot in that place again. Tell me you don't have power as a CNA. Because we spend the most time with the patients out of any other staff member. Phlebotomist might only see somebody for 30 seconds a day. X-ray techs may only see somebody once every stay. Doctors are only in the room for about 45 seconds. Nurses, they get a little more time. Nurses on average get 3 minutes with the patient. CNAs on average get about an hour of time with their patients. We are the face of that setting. So if you aren't communicating with your patients, if you aren't supporting your patients, if you aren't encouraging their communication, that person, that patient is going to base their opinion of the care they received on you, not on the MRI they received, not on the surgery that was performed, not on the medications they were prescribed. They interpret the way you treated them as the face of that facility.
And when you're a patient in the hospital going through your turmoil, which I've been there too many times, when these people are coming in to help you, you're so out of it. You don't know if they're a CNA, a nurse, or whatever. You just know that they're coming in to help you. And you remember who really helped you. And
Right.
who didn't.
Right. Help isn't help.
I am in this business at 50. I'm now 59 years old, and because I've respected what they do, and I've been in the hospital too many times. So
Yeah, remember, help isn't help if it doesn't help, right? So we have to understand that when it comes to communication, our approach is going to speak volumes. And that's why I spend a lot of time talking about the bucket of nice and, talking about paying attention to your patients and making sure they have everything they need before you leave. It helps you with time management, but it also gives them the impression that somebody here actually cares whether I live or die. And your patients really feel that. Patients, especially in acute care settings, are all afraid they're going to die. In long-term care settings, they know they're there to die. This is the last stop. When you go into a nursing home, there is no discharge plan. The discharge plan is when I die, what nursing home is coming to pick me up? Or I'm sorry, what funeral home is coming to pick me up? You don't think they need to talk about that? They need to talk. And yet we shy away from it. We don't want to talk about it. If you want to be known as a great conversationalist, close your mouth and open your ears. You don't have to know the right things to say. You just have to know how to listen. And the problem is we've all been trained to listen to respond, not to understand. When I talk, most people are sitting there thinking about the things they want to say. Turn that off. Turn it off. Just listen. What are they trying to tell you? And then reflect that back to them. It sounds like you're feeling a little afraid. Is there something I can do to help with that? That right there made me a great conversationalist. I didn't have to say anything about me. I reflected and I offered to help. Don't shy away from those conversations. Your patients need you. So this is all what I'm putting in this new guide, is to explain how to identify those communication questions, how to dissect them, and then how to choose the answer that meets that criteria, not necessarily in the words that you would use, but meets that criteria. Now, you guys will all do fantastic on those communication questions. Okay, good, good. I don't have it done yet. I was trying to get it to you today. It's not done. I'm still working on it. Hopefully I'll have it done by graduation. I'm working as hard as I can. I'm sitting way too much at my computer, way too much. I've got to start getting up and moving a little bit more so I don't develop blood clots. It's a real fear of mine. So I'm not going to have it done, by today to get it to you. So hopefully by next week, but I am going to ask you guys that when I get this to you, that you give me feedback, even though I'm not here to, or you're not here for me to remind you. That would be very helpful to me. I don't know for sure that I'll have it on Monday. Yeah, I'll be sending it through email. Yeah, I'll send you guys a digital copy through email. I don't think I'll be able to print it because it's going to be probably about 70 pages by the time it's done. And that's like, if I have that printed, yeah, that's going to be like $40 per student. Yeah. And this is a full sheet of paper, not a half one. So yeah, it's a lot. It's a lot. But if you go through it, you'll get 100 on the exam. It is going to be that good. So, all right, moving on, because I am like tangents, man. You give me an opportunity, I'll take it. All right, we know this. We follow the care plan. I'm going to just really blaze through these. We follow the care plan, the whole care plan, nothing but the care plan. We make observations, we report them to the nurse. Every skill starts with an opening. Every opening starts with a knock. You greet the resident, you address them by name, you introduce yourself by name and title, explain the skill, get permission, close the curtain, wash your hands, get your supplies. Gloves, don't wear them for everything. Wear them when you need them. And how do we know when we need them? If we're going to touch body fluids, personal skin, and non-intact skin. But here's the important part about gloves. Keep them clean for your patient. If you decide to wear them, fine, go for it. Knock yourself out. But don't touch a bunch of stuff with those gloves before you touch your patient. Pay attention because your patient's life may depend on it. Once you've got gloves on and you've touched the patient, be careful what you're touching in the environment. Yes, this environment has tons of patient cooties all around it. I get it. This cabinet, the bed controller, the curtain, the call light, cootied up, all cootied up. But we don't want to add to that unnecessarily. So pay attention to what you're touching with those dirty gloves and then remove your soiled gloves correctly. If you're going to use supplies, we have to have a clean place to put those clean supplies. Make sure you get your supplies after you wash your hands. Don't hold them against your uniform. Get your barrier first, put the barrier out, then go get your supplies. You may need a privacy blanket. They're used both for warmth and privacy. Remember, 2 reasons. And we're going to use them anytime the patient is uncovered or undressed. Don't snap it, don't shake it. Just lay it out over the sheet, pull the sheet down underneath. And if you use a privacy blanket and gloves, so like partial bed bath, you want to remove your gloves before you remove the blanket. Another supply we might need are linens. We use a lot of linens for a lot of different skills. You have to have clean hands to get your linens. You can't let linens touch your uniform. Don't snap or shake them. Nothing goes on the floor but shoes. Remember that. Clean rolls towards you, dirty rolls away. And unused items must be discarded. So don't, if you take washcloths and don't use them, don't leave them in the room for later. Patients always need to be in the middle of the bed. That's the safest place for them, in the middle of the bed. The way to do that is have the patient scoot toward you and roll them on their side. That way they're in the middle of the bed after the roll. We always roll them away from us, not toward us. So we remain behind the patient's behind. Washing rules. Man, we have used a lot of washing rules. And we're not done yet. So when we're going to be washing something and we're bringing water to the patient, there's a couple of rules we have to talk about. We don't put soap in the basin because we need that water clean for rinsing. We're going to use a paper towel to turn the faucet on. We check the water. It should feel warm, not hot, not cold, just warm. And we ask our patient to check it too, because my perception of temperature is different than my patient's perception of temperature. Whatever you wash, you rinse. Whatever you rinse, you dry. If you're washing a wet body opening, use that leaves method that we learned last class. We're going to see it again today with Peri-Care. Change the water if it gets cold or soapy. Don't get your surface wet, so protect your surface. Table will protect with a barrier. If you're doing foot care, the barrier goes on the floor. If you're working on the bed, a towel under the patient's more comfortable than a barrier. But protect your bedding. Let me back up. A towel is more comfortable under the patient as long as you don't expect body fluids to come out. Okay, because if we're going to be working under the peri area, we need a barrier there because it's waterproof. If you're just bathing the patient and we're just working with water, a towel is perfectly fine. Okay. If you're going to use lotion, warm it up first and then wipe off the excess. Anything that holds a fluid has to be cleaned. And for the test, we rinse it, we dry it, we store it. That's all we have to do. Rinse it, dry it, store it. Use a paper towel to open the drawer, though, because you don't want your soiled hand to touch that cabinet and make it any dirtier. We learned shoe rules last class. So this is the new one that we picked up. If the patient's feet hit the floor, we have to talk about their shoes because slipper socks are not enough. Remember that slipper socks don't help prevent all slips. They also don't protect against pathogen transfer, and they don't do anything to protect against sharps. So slipper socks really are not our ideal go-to, despite what you may see in the wild, okay? You really should have shoes on the patient if they're going to be walking. If we use a gait belt, we put it on around the patient's waist over their clothes. I don't know why that's a big deal, but over their clothes. You're going to tighten it just so you can fit 4 fingers between the belt and the patient, not too loose, or it'll slide up and won't be effective. We're going to count to 3 before we lift our patient to a standing position, making sure their feet are flat on the floor before we lift. When we stand them up, You want to give them a minute to make sure that they're acclimated. So make sure they're not dizzy if you're going to be walking them. If you're transferring them, you stand them up, pivot them, and then make sure they can feel that chair behind them before we sit them down. We're going to be talking about that skill in just a few minutes. Remember that you never ask a patient to sit in a chair to trust you that a chair is behind them. Don't ask them to sit unless they can feel that chair behind their legs. Anybody ever have that prank pulled on you at school? Yeah, somebody pulls the chair out from under you. You end up on the floor. Yeah, when you're young, that can be funny. I don't think it is, but it can be funny. When you're old, it usually results in a broken bone. The sad reality is that most patients in clinical settings have been dropped. Most patients, they're not going to trust you. Don't expect them to. Let them feel that chair behind them. That, to me, that is probably one of the saddest statistics in healthcare, is that most patients in most settings that are unable to transfer independently have been dropped. That's us. We can do better than that. Patient has to, I'm sorry, we're going to use proper body mechanics as well. All right. And then every skill ends with the closing. You have to end the skill with clean hands. So that is the very last action we take always. Before that, we're going to give them the call light. We're going to open the curtain. We're going to ask if they need anything, make sure the bed is in the low position and the environment is clean. You know, all of those nice things, but we don't care what order you do them in. Just do them all. Then you're going to wash your hands. If you have to document, you document after you wash your hands, and then you wash your hands again. Good. Now, before you end the skill on the state exam, before you say my skill is done or I'm finished or however you want to say it, before you say that, I do want you to review that care plan. Just make sure that there's nothing there that you missed. And if you have to, you can start over again. The evaluators will let you start over again. If you really messed it all up, you can start over in the middle. You can say, oh, my brain, I need to start over, and just start over. You're allowed to do that. If you do it too many times, though, they're going to assume you're not ready for testing. Remember, the test isn't about the test isn't about you proving that you are ready to take a test. The test is about you proving that you're ready to go to work. You ideally should be able to walk out of that testing room and go straight into work. But we don't really think about the test in that mindset. We think about the test as a step we have to get through. But that's not what testing is about. The testing is saying, okay, you're ready, go to work. So I get a lot of this online, you know, in the comments that I have and in the groups that I'm in. I really wish they would tell us our skills before we go into test. I want you to take a minute to think about how absurd that sounds. Because I'm not going to call you up the night before work and say, okay, I need you to be prepared to feed a patient. You've got a couple patients with hand and nail care. You're going to have to do some partial bed baths, some range of motion. You've got some incontinent patients, so Peri-Care will be important. You're going to need to know how to transfer a patient out of a bed and into a wheelchair, and you've got 6 feeds. I'm not going. Why? What? Do you hear how just ridiculous that sounds? And yet we want that for the test. I wish they would tell me what my skills are for the test. Why? They're not going to tell you what your skills are in a clinical setting before before you have to go in and do them. They're going to assume that once you're certified, you know how to do these things and you can go in and do them when I tell you to go in and do them. Yeah, I'm competing here. So we have to understand what the test is. The test is you saying, okay, I'm good. I've practiced. I've got this down. I'm ready to go to work. Let me show you. I'm ready to go to work. Put me in, coach. I got this. Okay. If you go into the test with that mindset, it really does make the test a whole lot easier. It really does. Right. All right. Well, I'm going to skip these. Yeah, we've gone over these. I'm going to skip these. I don't know how we've gone over a lot. All right. Flashcards are available for you if you want them. All right. Let's get into page 72. This is transferring a patient from bed to wheelchair. Does anybody have any questions before I get started? No? All right. Move that out of the way. Okay, if you look down here along the side, you're going to see all of the principles involved in this particular skill. They're all spelled out for us here, and we know all of these. We know to follow the care plan. We know to do the opening before we start the skill. We know to evaluate if we need gloves. We might not. Depends on the patient, not the skill. We know to follow those shoe rules that we learned last class, and we know to do the closing. What we don't know are these steps, which we're going to go over in a minute. If you look down here, somebody with your level of experience should be able to do this skill in 11 minutes or less. We're taking somebody from a bed and putting them in a wheelchair. They're giving you 11 minutes to do that. This is at most a 4-minute skill. At most. And that's if you're slow. Okay. It's going to take me a whole lot longer than that to teach it to you. But they're giving you 11 minutes. Don't rush this. Don't rush this. Your person is going to be a live testing student. You might be a patient for this. A live testing student. Mannequins don't really work well for this. We need somebody who can bear weight. This patient is going to be in a bed at the beginning of the skill. Well, that makes sense. We're transferring from bed to wheelchair. They've got to start in a bed, and charting is not required. Step-by-step instructions are located on page 73. Up at the top, you've got your care plan. You've got step-by-step instructions. And I'm going to be referring back to this graphic in a little bit. Supplies are at the bottom of the page. Shoes become important on this one. Your patient's starting out in bed. Most people in bed do not have shoes on. That means for this skill, you're physically going to have to put shoes on somebody before you transfer them. So shoes are a supply for this, but it's going to be their own shoes right beside the bed. Do not transfer somebody without shoes. Very important. Do not transfer somebody without shoes. We're going to use a gait belt and a wheelchair, and we're going to talk about the wheelchair at length in just a few minutes. Here's our care plan. It says transfer the resident from bed to wheelchair. The resident is unable to walk or take steps, but can stand with support. So I need you to put that patient in your mind. Unable to walk or take steps, but they can bear weight. If somebody cannot bear weight, they are not a transfer. If somebody has no strength in their legs and they collapse, that is not a pivot transfer. That is a mechanical lift situation. Make sense? Good. So I need you to kind of arrange your thinking along those lines. For the test, your patient is not going to collapse on you. They can bear weight. They just can't make their legs move. Okay. So it's a gait belt or transfer belt. Remember, it's two names, same item. Gait belt is a transfer belt. A gait belt or transfer belt is required to transfer the resident, and the resident will stay in the room. So we're going to take them out of the bed, put them in the wheelchair, and they're going to stay in the room. This is not where the patient's day ends. It's just where the scene ends. Okay. That would be like me asking you, hey, can you go put Mr. Adams in a wheelchair? His family's coming to pick him up to take him to Easter dinner. Okay, you would put him in a wheelchair and leave him in the room for the family. You're not going to take him, like the family's coming to get him. They're expecting him to be in the room, right? Can you imagine their shock and surprise if they walk in the room and he's not there? Like, where's grandpa? Now we're on a whole quest, right? Not cool. So we're going to follow the care plan. It says leave him in the room. We're going to leave him in the room. Good. Okay. All right, so we know all of these. We've learned all of these. We have to learn these. So a lot of this is going to revolve around how to use an actual wheelchair. So let me show you how to use an actual wheelchair. So I've got the wheelchair here. Wheelchairs are usually, hey Jake, can you lower the camera for me? Thank you. Okay. So wheelchairs are usually kept in the folded position for storage. It just kind of makes them a little bit smaller, easier to store. To open a wheelchair, you just lift up on the handles to get the big wheels off the floor so we don't have so much friction, and pull the handles apart. It's that simple. There's no buttons to push or levers to pull, or it's all mechanical. To close up a wheelchair, you lift up on the center of the seat and the two halves go back together. Okay, good. All right, so wheelchairs, there's a couple of features. We all think we know how to use wheelchairs. We actually don't. There's a couple of features to this that I need to bring to your attention. The first one, which is the most important one, are the brakes. Wheelchairs have brakes, and if the wheelchair is not currently in motion, the brakes should be on. So I don't put a patient in a wheelchair and just walk away from the wheelchair unlocked. Floors are rarely level. When you have mass in a wheelchair and the floor is not level and the wheelchair starts to roll, it's going to pick up momentum because of the mass in it. Does that make sense? The only thing that's going to stop that wheelchair is whatever it runs into. Now you've got an injured patient and possibly another injured patient because that's the thing it ran into. Wheelchairs have to be locked. Now, in order to lock a wheelchair, you have these levers. I am going to trip over that chair. Okay. You have these levers. Now, you can see them here on the screen. They're levers that are in front of the big wheel. And yes, it's the same wheelchair, just different leg rests. Okay, thank you. Good. All right, so this is the lever right here. If I pull back on the lever, do you see how this metal bites into the wheel? That's how it's going to stop it from rolling. To disengage, I push forward, and now I've got a gap, and the wheel can roll freely. So wheelchairs come in two different varieties. Some of them you pull back to lock. Others you push forward to lock. It's not about knowing forward or back. It's about seeing which way does this metal bar bite into the wheel. Some of them it'll be back, some of them it'll be forward. Good? Make sense? There's no one universal rule there. I don't know why. All right, Jake. You'll have to, go back down for me. You'll have to zoom in a minute as well when we get to the leg rest. All right. So there's two other pieces to the wheelchair that we have to talk about. Now, most people have a vague idea about, but these things can really trip you up. So we have foot pedals, and then we have leg rests. So the leg rests come off of the wheelchair, and they hold those foot pedals. Foot pedals go up and down. Leg rests swing in and out. Okay? So foot pedals up and down, leg rests swing in and out. Two different mechanisms, but super important. All right, Jake. Zoom in. All right, so this is the leg rest here. Right now it's locked in place. It doesn't go anywhere. But there's a little catch on the back where it attaches to the wheelchair. If I release that catch, they swing right out. To put it back in place, you just snap it forward. It clicks in place, and now it's locked. So this little catch lets me swing it out. That locks it in place. Okay. Try not to move it.
My feet is delayed. Oh. There we go.
I'm going to turn it just a little bit. Leave the camera there. Okay. So this right here is our catch. Okay, good. When we're trying to take a patient out of a wheelchair or put a patient into a wheelchair, we want nothing in our way. We want a wide open space. So this looks okay. It's not. To put a patient into a wheelchair or take a patient out, we have to do more than just move those foot pedals out of the way. We have to move these leg rests completely out of the way to create a wide open space for our patient. If you don't move those leg rests, you're not going to pass because they're a tripping hazard. I'm going to explain why in just a minute. But a common mistake on the state exam, these things, these leg rests, they aren't really truly attached to the wheelchair in the way that you think they are. They come off super easy. And this can happen to students. I mean, it didn't take any effort, right? So students in a testing center, if you don't know how a wheelchair works and you accidentally pull this off during the test, you would probably have no idea how to put it back on, right? We're going to need it in a minute. So students get all flustered about, oh my gosh, I broke the wheelchair. I didn't break it. There's 2 holes here, right here, 2 holes. And these holes just rest on these 2 little protrusions on the wheelchair. All right, Jake, zoom in. I know this is one we do a lot of zooming. Okay, see those little knobby things here? These holes, these holes are going to fit right on those little knobby things. And now it swings freely. So if you accidentally remove that leg rest, no big deal. Just put it on the little knobby things and you'll be good to go. But that trips up a lot of students on the state exam because they panic. They don't know what to do. What do I do next? So I always try to point that out when possible. Yes, good point, Jake. There's going to be some places you go and you're going to find a wheelchair. It doesn't have any leg rests on it. Look in your soiled utility room. They're probably there piled up. Go find some, clean them, put them on the wheelchair. You just wipe them down. Cleaning, you just wipe them down with a antimicrobial wipe. Like we've got wipes everywhere in facilities. Just grab a wipe and wipe them down. That's all you have to do. Okay. All right. So we have these foot pedals that go up and down. We have these leg rests that go in and out, and we have brakes. Those are the 3 things I need you to know about wheelchairs. How we use wheelchairs, the configuration of those things is going to depend on what we're doing at the moment. So when we have a patient in a wheelchair, when it's in use, this is the one that we're going to be using, right? Foot pedals down, leg rests forward. They've got somewhere to put their feet. I'll explain why that's important in a minute. This is what we traditionally think of with a wheelchair. You don't want to try to store a wheelchair like this because if the leg rests are forward and the foot pedals are down like this, when I try to collapse this wheelchair, those leg rests clash and it'll actually break those little knobby things off that the leg rests are resting on. So when you're going to compress a wheelchair for storage, you need to fold these foot pedals up before you bring the wheelchair back together. Okay. So this is how it looks before we compress it. This is how it should look when we're putting a patient in or taking them out. We want those foot pedals up and the leg rests out of the way. You might have a question on the state exam with images like this asking you which wheelchair configuration is appropriate for transfers. Okay. Good. All right. So I felt so bad when I read this lawsuit. This was horrible. And I feel bad for the patient, but I really feel bad for the worker. I really do. So let me paint you a picture here. We had an elderly woman with her daughter who went into a facility to have some imaging done. I think she was having x-rays or an MRI, some sort of imaging. And this happened in Georgia. And she was done with the imaging. The daughter goes out to pull the car up, right? Older patient in a wheelchair, pull the car up around the circle. And the receptionist who's sitting there is watching. She calls transport, hey, I got a patient ready to go. Can you come down and transfer the patient? And transport says, yeah, I'll be down in a few minutes. Well, they're waiting and they're waiting and they're waiting and no transport. Daughter's sitting in the car. They're backing up traffic, right? Other people are trying to get in to unload and load. This receptionist is sitting there, patients in the wheelchair out the door, just looking out, waiting. And the receptionist thinks, okay, I got this. I can solve this, right? And it's something we would all kind of think, I got this. I can solve this. And she gets up and she takes the patient outside and she helps transfer the patient. She had not been trained on wheelchairs. She was a receptionist. She did not do clinical work. Not been trained on wheelchairs. And she did this. She folded the foot pedals up. And when she went to transfer the patient who had limited mobility, could not lift her legs high, tripped over the leg rest and fell between the car and the curb. She ended up breaking her leg or her hip. I think it was her hip. So she didn't get to go home. She was then admitted. The receptionist was fired. Now, she was just trying to do a good deed, and I understand her mindset, and I feel awful for her because she was trying to do something good, and she ended up losing her job over it. Why did she end up losing her job? That's right. She went outside of her scope of practice. She had not been trained. Now, we all think we know how to use a wheelchair. This should be intuitive, right? I've seen a wheelchair a million times. I got this. But there's always something that you don't know about a topic that you haven't been trained on. You know what you know, and that's great. The problem is those gaps, you don't even know are there. You have no idea where your gaps are. You have no idea that they exist because you haven't been trained. How many of you guys learned something in this class that surprised you? You had gaps that you did not even know. You had no idea those gaps existed before you took the class. And that's the important thing I need you to understand about being a CNA. You have gaps in your knowledge that you don't even know are there. You do not step outside of your scope of practice for any reason because it's the gaps that are going to cause injury. I feel bad for this lady. I do. I really feel bad for the patient, right? I mean, yes, I feel horrible. But I really feel bad for this receptionist too because she was just trying to do something good and nobody had ever told her that it's the things you don't know that are going to get you in trouble. Okay. What should she have done?
Or not done anything at all.
That's right. Yeah. Not move the leg rests. She should have just waited for transport. Yep. You can make another phone call if you need to. You can tell the daughter you're going to need to move and wait. But should she have ever intervened clinically? No, outside of her scope of practice. All right. So, did I skip one? No. Where? Oh, I have these. No? Huh. I'm missing a slide.
Maybe no.
Yeah, I'm missing a slide. Okay. So, Jake, I hate to do this to you. I'm very sorry. Can you bring the black chair out? The one you're sitting in?
Yeah.
I'll trade you. Take this. Just set it here next. This is the slide we're missing, is a comparison. So we'll do this in real time. Okay. Look at the seat height difference between these two. Can you guys see that from your angle? Can you see that this chair is lower than this one? That's actually important. It's not something that we normally pay attention to, but it's important. Wheelchairs are taller than normal chairs. Now, if you remember me saying I had a problem with normal chairs because my feet don't hit the floor, right? I got short legs. Well, it's way worse in a wheelchair, right? Because a wheelchair's taller, which means my legs are going to dangle. Does that make sense? You guys see physics? Get that? Okay. All right. So here's the problem. On the back of your legs, you've got arteries going down to your feet. You've got veins coming, back up to the heart. And these two systems kind of mirror each other. But veins are always on top, actually. Arteries are buried deeper. Veins are on top. But they kind of run like side by side or like close to on top of each other. All right. Why do we care? Well, when you have a patient sitting in a wheelchair and their legs are dangling and they're not flat on the floor, and they shouldn't be flat on the floor because the wheelchair's taller, right? We've got that dangling thing going on. Well, dangling is actually very, very dangerous because as the patient is sitting in the wheelchair, their feet are not on the floor. This seat edge, okay, this edge of the seat right here is their legs are heavy. Gravity on Earth is going to pull that heavy down. So those blood vessels at the back of the legs, particularly right behind the knees, are going to get compressed with the weight of the legs. And there's nothing to relieve that, right? The weight just pulls all of that, or the gravity just pulls all that weight down, squishes those blood vessels, particularly the veins. And what this does is it keeps the blood from being able to go from these lower legs back up to the heart. We've created a 90-degree bend and squished all the blood vessels, and blood is not going to be able to move back up to the heart very well. So all of that fluid stays down here, which means that we have a patient at risk for swelling. Make sense? Swelling. And worse, way worse than swelling, are blood clots. Because inside the veins, right, we have to get blood from our feet back up to our heart. It's a low pressure system. So blood can't really go uphill without a lot of pressure behind it to push it uphill. It just doesn't work that well. So our veins actually have a mechanism inside these little valves that separates veins into two chambers, kind of like a ladder. And as the heart beat, it pushes blood from this chamber down here into this one, and then those valves close. And now the blood stays here until the next heartbeat, which pushes the blood into this chamber, and then the valves close and the blood stays there. And blood literally climbs this ladder back up to your heart. Okay, it's pretty cool. So we have these little valves, these little protrusions on the inside of our veins. Now, when we squish those veins down, what happens is this blood can't get from this chamber into this one because we've squished them. And blood that stays here, do you guys remember what I said happens to blood that slows down or stops? We talked about that last week. Anybody remember me saying that? It clots, that's right. So blood that slows down or stops tends to clot. So what is my patient at risk for? So not just swelling, but blood clots. Blood clots ever a good thing inside the body? No, not even on a good day. And this is why I get really concerned about the amount of time I'm spending in a chair. That's right. Flights are a really bad thing. So the way that we help with this, the way that we help avoid this is to make sure that our patient's feet are on those foot pedals, and those foot pedals are actually relieving the pressure on the backs of the knees. So if you look at the wheelchair, the leg rests on the wheelchair. Jake, I'll need you to zoom in one more time. So when we look at these leg rests on the wheelchair, you can see that there's adjustments to them. You're good. You're really going to have to get close. There we go. So right here are little holes. You can't really, it's a little blurry, but you can see this little button thing here. Yeah, it's okay. It's good enough. Okay. So you got these little holes. So you can actually push this button and pull this up or down. I can't do it right now with my hand. Pull it up or down to extend or retract to make sure that we're relieving the pressure on the backs of the knees, that those foot pedals are in the right place. It would be the equivalent of me putting a block under my feet when I'm sitting in a chair so I can actually put my feet flat down. Yeah, it's just a little button. It's just a little button. You see that button right there? Okay, you press the button and you pull. Hold on. Oh, thank you. Yeah, I forgot about that. I can't do it, but yes, this, oh, I heard it. This, I just don't have any strength in my hands today. But this pin right here, and yeah, you have to release the lever. Not all have that extra lever on it, but just adjust that foot pedal for support for short people or longer people. Because if you've got it, this is the shortest, right? But if you've got it, if you've got somebody who has like super long legs, this is going to make their knees like up toward to their chin. That's going to be uncomfortable. So you can extend that out. Okay, good. Makes sense? Okay. So those foot pedals actually are way more important than we think they are. They actually serve as a structural support. Now there is a different type of wheelchair that I do want to go over. I don't have a slide for this. There is a different type of wheelchair. Those wheelchairs are lower to the ground. They're actually usually a little bit lower than a regular chair, lower to the ground. And they have 4 small wheels, not 2 big ones and 2 small ones. They have 4 small wheels. Those are called companion chairs. They don't have footrests or foot pedals or leg rests. It's just a chair and 4 wheels. Those are designed for, have you ever seen the little people that sit in a wheelchair and they just kind of pad and move all around, right? They're designed to be maneuverable. They're designed for the patient to be in control of their mobility. So they're set up a little bit differently. You're not going to have that on the state exam. We don't use companion chairs on the state exam, but you do need to know that there is a different type of wheelchair that is lower. You'll know that it's a companion chair because it has 4 small wheels rather than 2 big and 2 small. Okay, but those don't have the same setup as this one. This one's designed to get the feet off the ground so we can move them where we need to go. Companion is designed for the patient to reach the ground to move themselves where they want to go. Okay, all right, so we're going to get our patient sitting up on the side of the bed. This is not hard at all. People think this is way harder than it is. It's not hard at all, as long as you're using the right technique. So in order to get this patient sitting on the edge of the bed, I don't want this wheelchair super close, because if the wheelchair was super close, when I go to swing his legs off the bed, they're going to hit the wheelchair and probably injure him. So I want the wheelchair within arm's length, but not too close that the patient's going to hit it. I want to be able to grab it when I need it. Good. So wheelchair close, but not too close. And then we're going to swing that patient around so they're sitting on the side of the bed. And the way that we do that I don't have a slide on that. The way that we do that is everybody wants to do like a honeymoon carry on this, like arm under the shoulders and one under the knees, a honeymoon carry, right? This does not work. This is good if you're going to carry somebody over a threshold, but not to swing them around. So in order to swing a patient in this configuration, I had to push with this arm and pull with this one, and that torques my back. That's not good. So I'm going to put my hand under the shoulders, just like a honeymoon carry, but this one is going to go over the knees instead. And when I am in this configuration with a wide base of support and bent knees, it's a clean pivot. And you can actually pivot somebody your body size, maybe a little bit bigger, with no problem at all, as long as you're over the knees, not under. Okay, so we're going to pivot them around on the side of the bed. You're going to see this in the video. I do this with my son, who is significantly taller than me. And it doesn't take any effort for me at all. I just swing them around. Okay, even though he's much taller than me, it's the right technique. All right, we want to make sure that our wheelchair is set up for the transfer. So we want to get these foot pedals folded up. We want to get these leg rests moved out of the way. And this is a testing checkpoint. We're going to pivot that patient around so they're sitting on the edge of the bed. Give them a minute to acclimate. Make sure that they're not dizzy, that their blood pressure regulates, that their pulse kind of slows down, because this is a quick turn, guys. Your patients can get a little bit off balance from this as their body tries to accommodate this new position. Do you guys remember what I said about blood trying to get from the feet back up to the heart? Right? That it's kind of hard to do. Well, remember that when we're laying down, blood moves very easily because there's no real blockage, right? There's no gravity to fight against. It's just going to kind of move where it needs to go. So when you're laying down, everything's easy. When you sit up, all of a sudden the blood that's up here, whoo, falls straight down, and that can make us dizzy, off balance. So we have to give our patients a little bit of time to acclimate, because remember, on planet Earth, we have gravity. Okay. All right. As the patient is sitting there acclimating, I'm going to do some work, because I got lots of patients to see, and I'm just not going to sit there and stare at them. While he's acclimating, called dangling, I'm going to put his shoes on. I'm going to get that gait belt around his waist. He is acclimating. I'm going to be working. Okay, so shoes on, and then the gait belt around the waist, same way we use the gait belt for ambulate. And then I'm going to bring that wheelchair super close. This is actually, remember this graphic is in your skills book on your step-by-step page. I told you we're going to come back to this graphic. This isn't quite close enough. Looks pretty close, doesn't it? Not close enough. I only want to be able to fit a piece of paper between that person's leg and this wheelchair. I want it that close, because remember that our patient cannot take steps. You guys remember that from the care plan? Cannot take steps. So if I've got this wheelchair in this position, when I stand this patient up, right, I'm going to put my fingers here and I pivot them around, look how far away from that wheelchair they are. Can they feel that wheelchair behind them? That's too far. So when you get this, you want this wheelchair super close, because the furthest foot is where they're going to pivot. That's where they're going to end up. So you want it so close that this foot is almost under that wheelchair, so that when you pivot, you see how much closer I am? They'll be able to feel that wheelchair behind them. Good? Make sense? So this looks close enough. It's not. Your patient will fall. All right, so we want to make sure that wheelchair is locked before we lift the patient. So remember, your wheelchair might go forward to lock. It might come back to lock. What we're looking for is this metal to bite into that wheel to make sure that it's locked. All right, so we've got our shoes on, we've got our gait belt on, we've got the wheelchair locked. It's super close to our patient. We're going to use that same body mechanics. 1 foot in front of the feet, 1 foot beside the body. We're going to bend at the knees, not the waist, with a wide base of support before we lift. And we're going to lift them to a standing position and pivot all at the same time. So very smooth. We lift, pivot. And we want to make sure they can feel that chair behind them. I don't want to be standing there holding this patient and asking, can you feel the wheelchair? And waiting for them to say, yes, I can feel the wheelchair before we say, that's a long time to have that patient standing. So what I do is I get the patient sitting on the side of the bed, I put the shoes on, I put the gait belt on, and I say, Mr. Jones, I'm going to lift you to a standing position and pivot you to the wheelchair. When you feel that seat behind your knees, I want you to say, sit. Okay? Put your hands on my shoulders, 1 foot in front, 1 foot beside, reach around, grab the back of the gait belt. All right, Mr. Jones, remember, when you feel the chair, say sit. Ready? 1, 2, 3, up, over, sit, down. Okay? Shortens how long you're trying to support that patient. Good? You don't have to use sit. You can use any word you want. All right. So once we get the patient in the wheelchair, you want to make sure their hips are back against the seat. We're going to bring the leg rests forward, put the foot pedals down to support those feet. We're going to take the gait belt off. And you're going to make sure that your patient overall looks comfortable, that they're in the right position, that their body alignment is good, that, you know, their feet are well supported, that everything looks good and they're ready to go. You're going to give them their call light like we do for every other skill. But there's one more thing about this skill that I want to bring to your attention. When I transfer this patient, I get the patient sitting on the edge of the bed. I bring the wheelchair close. They've got their shoes and gait belt on. I've got this wheelchair locked. Hands on shoulders, 1, 2, 3, up, over, sit, down, right? Patients in that wheelchair. What are they facing? Yeah. Would you want to be sitting in a wheelchair in a room facing a wall? Yeah, they want to look at something, right? So TV, the hallway, out the window, they need something to look at. If you put somebody positioned to look at a wall, it can actually feel like a punishment. Because years ago, we used to put people in the corner to stare at a wall as punishment. So remember that the memories that we formed when we were very young are the ones that stick with us. You guys remember that? If you leave a patient facing a wall, especially an older patient, that's going to feel very punishing. So remember that when you get a patient in a wheelchair, we have to get these leg rests out of the way. So you're most likely going to kind of turn the wheelchair, get the leg rests and the foot pedals down, get them all situated. Do not leave them in this position. Leave them in this position. Get the wheelchair in place. Make sure it's locked before you leave them. Bring the leg rests forward, the foot pedals down, and support the feet, and then give them their call light and do your closing. Good? Make sense? Good? Don't leave them looking at a wall. All right, so let's see how we're going to use these principles to check off this checklist. It's kind of a long checklist. A lot of points here, but let's take a look and see what they're testing us on. We're going to follow that care plan, and boy, there's a whole lot on there for that one checkpoint. Remember, if you miss any part of that, you don't get the check mark. So we're going to transfer them using that pivot transfer. something that happened a couple of years ago in testing. There was a school out there. I don't know who it was. I don't know why they were teaching the way they were, but there was a whole bunch of students that came through. So we know it was a school. A whole bunch of students came through and all did the same thing. For this skill, they walked in, they put the wheelchair next to the bed, and they asked the patient, can you get up and sit in the wheelchair? Now, that might be, right? In a clinical setting, you might have a patient that can transfer themselves. You just need to bring the wheelchair, make sure everything is safe, make sure everything is out of the way. That is absolutely a possibility in a clinical setting. Why won't it work for the test? Say it loud. Care plan, that's right. This care plan says this patient. Do you guys understand that? Good? Okay. So we want to make sure that we're giving them the support they need. We're actually doing the transfer here. We're going to do our opening and get those check marks. We're going to evaluate if we need gloves. For the test, your patient is fully clothed because it's another testing student, holding on to all of their own body fluids like a champ. There's no open skin to be seen. Do you need gloves for the test? You might in a clinical setting. Go by what the patient is needing. All right, we're going to use those shoe rules. Boy, those are going to have a lot of checkpoints on this one. We're going to use our wheelchair knowledge that we just learned, and then we're going to do our closing. So for this skill, the technical steps make up the majority of this skill, where a lot of the other ones we saw, all of our principles made up the majority of the skill. This skill, highly technical. All of these things that I've been talking about are going to count. Good? This care plan is only for this patient. That's it. Nobody else. This one walks on her own. She doesn't even use a wheelchair. This one, she uses a wheelchair, but she transfers herself. This one can't support weight. He has to have a mechanical lift. Every one of these patients is going to be different. Okay? All right, Jake, go ahead and play the video for us, please.
Hello.
Good afternoon, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. Would you like to get out of bed and into the wheelchair?
Yes, that'd be great.
Okay, I'll be happy to help you with that. Let me close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'll grab the gait belt. And I'm going to bring the wheelchair within reach, but not too close to the bed. All right, Mr. Jones, I'm just going to remove your sheet. We'll pull it all the way to the end of the bed. And I'm going to help you sit up on the edge of the bed. So to do that, can you scoot your body toward me? Bed is locked. You're going to cross your arms over your chest and relax. I'll do all the work. I'm just going to pivot you around so you're sitting on the side of the bed. Please let me know if you get dizzy or unstable at all. So I'm going to wide base of support, leaning against the bed, making sure the wheels are locked. I'm going to place one arm all the way under the shoulders and the other arm over the knees. Bending at the knees, not the waist, and we're going to pivot. 1, 2, 3. Good?
Yes.
Okay, you can relax your arms. I'm going to help you put your shoes on now. Okay, first shoe and the second shoe. And are your feet flat on the floor?
Yes.
I'm going to place this gait belt around your waist, making sure that it's not twisted or kinked. And we'll secure it by sliding the gait belt into the first guard, pulling it so that it's snug. We'll check it with 4 fingers, and then slide it through the second guard. I'm going to bring the wheelchair close at a slight angle, almost touching the patient. And we'll lock the wheels. All right, Mr. Jones, can you bring your feet together and back a little? Are your feet flat on the floor?
Yes.
You're going to place your hands on my shoulders. I'm going to lift you to a standing position, pivot you, and when you feel that seat behind your knees, I want you to say sit, and I'll help you sit.
Okay.
Okay, you're going to place your hands up here. And on the count of 3, we're going to lift and pivot. 1, 2, 3.
Sit.
And we'll remove that gait belt. Okay, and I'm just going to bring the gait belt behind you and turn you around to get your feet onto the foot pedals. So we're going to turn around. I'm going to bring the first foot pedal forward. Make sure it locks into place. And then place the foot on the foot pedal. We'll then lock the wheelchair. I'll lock this side, support your leg, bring the leg rest and the foot pedal, and support the foot. Are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Let me get your call light. Here's your call light. If
Thank
you need
you.
anything at all, just press that red button and somebody will be happy to come help. I'm going to open the curtain and go wash my hands. On the way, I'll return the gait belt to storage. After washing my hands, I'll think about my skill, make any corrections, and tell the evaluator my skill is done.
I have a question. that will
Yes.
Probably put you in a tangent, but if you don't have time, I can wait till later.
What's the question?
So one of the issues with becoming a CNA and so many years and getting older, and I read these Facebook pages, they're always complaining about how much work and killing their backs.
Mm-hmm.
Do you, in your opinion, feel because so many CNAs are not doing the using their knees and they're just trying to rush and they're
So body mechanics is going to have a significant impact on this, for sure. And in order to understand that, let me point you to like the construction industry, right? So there are a lot of industries out there that deal with lifting and moving heavy objects. And yet they don't have the same failure rate, okay, of, work comp cases and things like that for back injuries that medical does. So I find it very ironic that the one industry that actually developed body mechanics has such a poor adherence rate to those principles. And I don't know whether it's just people don't think that they're important or that they're immune to injury or just not thinking about it because they've got so much to do. I'm not real sure what the.
And also when you're younger.
Sure, yeah,
you
it
do it because when you get older, you're gonna regret it.
yeah, it's not as important when you're young. We all think that we're invincible when we're young. So I think that has something to do with it. The other issue is that, and this can't be overstated as well, right? When you're working with heavy objects that are truly stationary, solid, no, if you're going to pick up a concrete block, that concrete block is not going to change. Its form is its form, right? When we're working with patients, that's not always the case. You can have somebody who was bearing their own weight and now all of a sudden their legs just gave out from under them, right? So the mass that I'm going to use some technical terms here, but the mass that we are moving or working with is a changeable mass, where in other industries, the mass is static or, it doesn't change. Does that make sense? So there is a little bit higher rate of the potential for injury. So this is why I stress so much to watch the patient. Your attention should be on the patient, because most of the time your patients will give you some clue that something is not right here. And you can adjust your stance, your body mechanics, get them on the floor quickly, and that, will kind of help mitigate some of that. Does that make sense? So you also have to think about your own limitations. I'm getting older now. I still have upper body strength. We just did these videos a year ago. So I still have a lot of that same, upper body. I still have the same level of mobility. I am getting older, but I'm still able to do this. Now, I can't get on the floor anymore. That's a problem for me. That's a limitation that I have. But that just means that I have to increase my awareness of my own limitations and ask for help when I need it. Does that make sense? I'm also not going to go into settings where, getting on the floor is going to be important, So I want to make sure that I'm matching my skill level and my limitations to the work setting that I'm trying to get into.
So for the closing, it says to make sure the bed's in the lowest position, but for the skills where we leave them in a wheelchair or a chair.
Still have to make sure the bed's in a low position.
Okay.
Still have to. That's universal. It doesn't matter where the patient could be down in X-ray. You've got to make sure the bed's in low position. And there is a reason behind it, which I'm not going to get into because of tangents. There is a reason behind it, but that is a concrete, immutable law that all CNAs have to adhere to. That if you're not currently working on the patient or on the bed at that moment, that bed has to be in the low position.
And generally, the patient is able to lift it up on their own, so you're not really knowing when you're not there.
No.
If they're lifting it up, or
Patients generally do not raise the bed. They can raise the head of the bed, they can raise the foot of the bed, but the bed itself, the entire height of the bed, is generally not within the reach of the patient. So like this bed, the only way to raise this bed is a crank at the bottom. Patient can't get to it. On hospital beds, like the one that you see in the video, to raise on the inside of that upper rail, the positioning rail, on the inside, the patient's allowed to raise the head of the bed or the foot of the bed. Buttons are there. But to raise the entire bed, that's on the outside of that rail. So I'm sure the patient could, if they needed, they could do a whole, Cirque du Soleil acrobatic thing, but chances are.
so most of the time, what I'm saying is the bed's going to be at the lowest position. You just have to make sure.
Unless you have raised it for some reason. But it's something that we have to pay attention to.
And the head and the foot has to be down as well.
Nope, head and foot is up to the patient. Whatever's comfortable for them at the end of the scale. We have to raise the head of the bed for mouth care, right? Anything to do with the mouth, if we're doing mouth care or feeding them or anything like that, we're going to raise the head of the bed. At the end of the skill, whatever they want. Whatever they want.
So is there going to be any skills that we need to raise the lower
For the
bed?
test, it's not required. Now, you're tall. So making an occupied bed for you may be difficult because it's going to require a lot of bending. I'm short. I'm closer to the bed. Not a deal breaker for me. But for you, because you are taller, raising the bed might be a good idea because it's going to simplify the skill for you. You're not having to bend as much. So do that for the test. That's fine. Raise the bed to a comfortable working height. No problem. As long as you remember to lower it at the end. Okay. Yeah. You know, I think it's something that you should use when it's appropriate. You should. I don't do it on the videos because it introduces a level of complexity that I just don't have the time to explain on a skills video. So all of these videos, I do the skill with the bed in the lowest position. And I can get away with that because I'm short and I'm not having to bend much. Now, if I were 5'10", and demonstrating these skills, that's poor body mechanics. So I would have to raise the bed.
In the beginning, it would be, if I was to raise or lower the bed, then it would be after I wash my hands in the beginning and then before I wash my hands at the end.
Yeah. After you've washed your hands in the beginning, I would use a paper towel to put the bed up. Just, you know, because your hands are clean, you want those clean hands to touch the patient. So I would use a paper towel. Or you could just put the head of the bed up before you wash your hands. That's fine too. Good. Questions? Just don't touch the patient. That's the big thing. Don't touch the patient. Good questions on the bed. Good questions. All right, we're going to, All right. Let's go ahead and take our break because we're going to get into feeding, and I've got to teach you a couple things about intake and output and recording food percentages, and that takes a little bit of time. So if I do the lecture first, we're going to be putting off our break till after 11. So let's go ahead and take our break now, get it out of the way, and then we'll get into the last two skills for today, okay? 64. Here we go. Oops. Try again. All right, page 108. Nothing new to learn here other than the test, the skill specific steps. That's it. So all the principles we've learned. There's no new principles to learn from here on out. So we're just going to recycle what we've learned. We're going to follow the care plan. We're going to do our opening. We'll figure out if we need gloves. We have to have a barrier. Linen rules apply. We're going to end with the closing. All those things are the same. You've heard me say them over and over. You should be rolling your eyes by now. Okay. So if you look at this page at the bottom, you'll see that somebody with your level of experience, which is none, should be able to feed somebody in 9 minutes or less. Now, most of you have had some experience feeding another human, whether you were babysitting or your own children or a sibling. Most people have some experience feeding another human. More importantly, we have plenty of experience feeding ourselves. This is not a skill that should be coming out of left field for you. Good? Make sense? You will be doing this on another testing student. So that means that you might be fed for the state exam. Now, I'm going to get to that in a minute. So we're going to put that aside for a second because there's some things I have to tell you about that as well if you're going to be the patient for this. The patient will be positioned in a chair to start the skill, and documentation is required for this skill. It is one of the 4 documentation skills. And if you remember, I said on day 1 that everybody gets a documentation skill. So you will get either pulse or respirations or feeding or drainage bag. You're going to get one of those 4. Respirations is the most common. That's the one that shows up on most of those 11 care plan sets on page 25. I believe feeding only comes on 1. So you don't have a huge chance to get this particular skill, but it's one of the easier ones. I would be rooting for it. Okay, it's not a hard skill at all. It's a little bit longer. It's 9 minutes, but that just means that you get a couple short skills to go with it. So all in all, not a bad deal. If you go to page 109, you can see the step-by-step instructions along with the care plan at the top and your supplies at the bottom. And this is the point that I remind you that every single one of these lessons has questions. If you have not been doing the questions after we go over the lesson, you probably should, because that will help you identify your own gaps, where your strengths and weaknesses are regarding that particular skill. Fair? Okay. All right. So let's take a look at this particular care plan. It says, feed the resident a snack. Let's underline that word. Snack. What are we feeding them? A snack. We are not doing a full meal here. For the test, a snack is a single serve pudding or applesauce cup. That is what you will have to feed your patient. Remember, I said we're going to have some specific instructions in a few minutes, but that's what you'll be feeding the patient is a snack. It's unable to feed him or herself. So the patient cannot feed themselves. It does not say that they're an invalid. It does not say that they can't swallow. It does not say that there are any special considerations. It just says they're unable to feed themselves. So imagine somebody who, a younger person who fell, put their hands out to stop themselves and broke both of their wrists. This person will not be able to feed themselves. So I do not want your brain to automatically go to a 90-year-old invalid that can't swallow and is drooling all over that's not who this is. Remember, this is another live testing student. They just cannot feed themselves. Good? Make sense? Good. The resident is sitting in a chair. in an inappropriate position for eating. Underline that. This is where the care plan gets real. This care plan is specifically telling you that no matter what your eyes say, this patient is in an inappropriate position for eating. So you may look at the patient and think, okay, they're fine. But what does our care plan say? They're not fine. That's right. They're in an inappropriate position. So this has to be addressed. Doesn't matter what your eyes tell you. This has to be addressed. Now we're going to address it simply by saying, can you sit up straight, please? Right? So there's nothing physical you have to do here other than say, please sit up straight. Make sense? But it has to be addressed because our care plan is telling us that their position is inappropriate. Now, when you are the patient for this, and you may be, the evaluators are going to give you two specific instructions. They're going to say, first, I want you to slump or slouch when you're sitting in your chair. And second, I want you to only take 4 bites and then refuse to eat anymore. Just say, you're done, I'm finished, I'm not hungry anymore, I don't want any, however you want to say it, I don't care, but stop eating after 4 bites. Okay, so those are the 2 pieces of instructions you're going to get. Slump or slouch, stop eating after 4 bites. So your idea of slumping and slouching is probably different than mine. How many of you guys ever seen a 10-year-old eat? Right? They do this. This is slumped. But it doesn't look inappropriate to us because we've seen all kinds of 10-year-olds eat this way. So your brain may say, this is perfectly okay. What does our care plan say? We have to ask them to sit up. Make sense? So you may be theatrical. You may be trying to win an Academy Award and do something like this. Right? Definitely not not appropriate for eating. So in that case, your care plan matches your eyes. But if the patient's just doing this, this may not trigger that same warning. Good? Make sense? So the evaluators tell the student to slump or slouch, but that doesn't mean your patient, or, the person playing the patient is going to be very theatrical about it. So make sure you address it. It says to document the intake on a food and fluid intake form. So if you go back to page 109, you can see that form right here. A little tiny image of it. Very small. Very small. But if you keep your hand there and turn to page 169 in your book, you can see a bigger version of that food and fluid intake form. These are available for you guys to practice with. So you should be practicing pulse. There's a documentation form there. You should be practicing respirations. There's a documentation form for that there. You should be practicing food and fluid intake. There's a documentation form for that there. And you should practice a drainage bag when we get Monday. There's a documentation form for it there. You can make copies of these and use them in your practice. That's fine.
So 4 bites, would that be considered?
We're going to get there.
Okay,
Yep.
all right.
Time out. Hold on. We're going to get there.
This is not on the same topic as eating, but is respiration, that's how many times they breathe in a minute?
Right. And we haven't gotten to that skill. I know. I'm hoping to put it in at the end of today. I know. I talk too much.
I read it in the yellow book, but I was just
I
looking for-
tried so hard. So the last class, at the beginning of the year, I redid all of these slides. So we have the new version of the slides. There's 1,500 slides that I created for this. And I create every single thing myself in-house. Huge project. And the first class that I did really good on time. We were so proud. Jake and I were so like, yes, we finally got it. We're not running over. And then I got comfortable and started talking again. So I've got to learn to stick to the slides. And yeah, Jake's got to throw stuff at me to keep me on track here
It
because
sounds so on track though, so it's like hard to tell if you're off topic.
I know it is. And it's all relevant. But it's taking away from what I need to be presenting. So yes, we will get to respirations, but yes, respirations is breathing. It doesn't take me long to teach you that one. It's not a hard skill at all. It's a very short skill, but we'll get there. All right. So we already know all these principles, nothing here to learn, nothing to see. We're going to do them all like we always do. But we are going to learn some skill specific steps. Now, none of these are hard. You actually know most of this because you feed yourself. And you've probably fed other people. This is not earth-shattering. This is not anything new, but there are some aspects to this that are new that we do have to talk about. Now, what makes this skill so difficult is that it doesn't follow a lot of our normal rules. It's different. So one of the ways that it's different is that we don't use a barrier on the table. We don't go get a chucks because our food tray is the barrier. There is one, we're just not getting one. It's already there underneath our food, okay? So you don't have to go get a chucks to use as a barrier. You got a food tray. Now, at the beginning of the skill, the evaluator is going to put a student, in the chair, tell them to slump or slouch, only take 4 bites, and they're going to have a food tray on the table with a single serve food item, pudding or applesauce, a fork, a spoon, a napkin, and a cup of water. It'll already be on the tray, on the table, ready for you. You won't have to do anything. You don't even have to check the tray matches the patient, which I think they should, but I don't write the test. So you don't even have to check that it's the right tray for the right patient. Please do, because we are what we eat, okay? You don't have to do that. But this skill doesn't follow all of our normal rules. And so we don't have to go get an extra barrier, but we also aren't going to close the privacy curtain for this one because eating is a social event. We talk when we eat. You don't talk with your mouth full, I know. But have you ever walked into a restaurant? Is it dead silent? No, restaurants are kind of one of the noisiest environments that you can be in because people talk when they eat. When you're chewing, I'm talking. I'm telling you about my day, what's on my mind, what's going on. When you swallow, I take a bite and I'm chewing while you respond. We talk while we eat. And in fact, it's way more important than that because most of our celebrations revolve around food, baby showers, food, weddings, food, birthdays, food, graduation, food, Easter Sunday, food, Christmas, food, Thanksgiving, food, 4th of July, food, right? We use food on every single social event. And a lot of times the social events revolve around the food. So to think that food is not social is just mind-blowing to me. Do not feed somebody in silence. They won't eat. It's awkward. It's weird. They're going to feel like you're staring at them. And we don't even do this with babies. When you're feeding babies, you aren't quiet. And yet we do that when we're feeding adults. We sit there stony-faced in silence and we wonder why they quit eating. Because it's awkward. So we have to have a conversation. We don't close the privacy curtain because we don't want to isolate the patient. And we are going to have a conversation with the patient. And you're graded on that conversation. It's the only skill that you're graded on having a conversation. Now, the conversation doesn't have to be real. You can make something up. Okay. You can talk about a movie on the big screen later today. You can talk about, did you see those little kids come in and do the Easter egg hunt, right? It doesn't have to be real. Make something up. That's fine. But the point is, have a conversation. I like myself, when I am working with patients, I like to look around their environment for ideas of topics. And most people have something in their environment that I can use to kind of jumpstart the conversation. Child's drawing on the wall. That's a great conversation starter. Who drew that? Do you get to see them often? Where do they live? Just conversation. How many children did you have? Conversation. Make the conversation about them. People will talk about themselves all day long. Okay, make the conversation about them. But there's my favorite, though, especially if I'm working with a patient that isn't eating well. My favorite thing to do is to look around and see if I can find a picture of them. And usually, especially with our older patients, there's a black and white photo somewhere of the woman dressed to them. These women put us to shame, right? They knew how to present themselves. And they're usually with a man in uniform. And I'll point to the picture and I'll go, oh my gosh, did you know them? Were they movie stars? How beautiful. Look at her. And watch that woman sit up a little straighter and say, oh no, honey, that was me. Now, what I've done is I've just complimented her, and I knew what I was doing the whole time. I've complimented her. I've improved her self-esteem, and therefore that will improve her appetite. And it will also give her a platform to begin a conversation. The clues that your patient has in their environment are all open for you to talk about. We don't take our deepest, darkest secrets and put them on the wall. Okay? Anything that is in the patient environment is fair game for conversation. But if I'm in a dining room, of course, there's nothing there for me to draw from. So what do I do then? Well, I have some questions that I keep in my back pocket. And one of my favorite ones is, I'm thinking about going on vacation. What's the most exciting place you've ever been? I need some ideas. What's the most exciting place you've ever been? Great question, right? And because all of you guys are now thinking, I don't know, what's the most exciting place I've ever been? Well, and you're going through all of the trips you've ever taken and you're kind of cataloging them and trying to sort through them and figure out which one is the most, interesting, right? And you did that and I didn't even direct it at you. But what is interesting about this, I've learned a lot of stuff from my patients, a lot of things. And I've actually met some very interesting people. I met a man that was knighted by the Queen of England. Now, tell me I didn't have something to talk about there, right? Tell me what that was like. Oh my gosh, that's amazing. So you never know who you're going to meet. I've met people that were involved in space and aeronautics. I've met CEOs of Fortune 500 companies. I have met a woman that had, I think, 16 or 17 children. And they all grew up to be successful. That is an accomplishment. You never know who you're dealing with. Every person has a story. This is your opportunity to find out what their story is and to have the time to do that. But sometimes your patients will surprise you. I was working up in Citrus County. This is way back in probably the early 90s. And I went to see a patient at an assisted living facility. Now, she was in her late 90s, sharp as a tack. Her mind was absolutely there, had great memory and recall. But physically, she needed some help. And she had these horrible wounds on her legs. And we had to go in 2 or 3 times a week and do complete dressing changes. And this was a very long dressing change. It was going to take me probably 45 minutes to take the old one off, clean the wounds, put the medication on and redress. This is a long process. So I pull up a chair. We're going to be here a while. So I'm ask her my standard question. This is the first time I'd ever seen her, pull my standard question out of my pocket. So Miss Mary, I'm thinking about going on vacation. What's the most exciting place you've ever been? And her reaction to this was, now guys, this was back in the late 90s and I still remember this conversation. Okay. She says, oh honey, I've never been anywhere. Okay, we're in Citrus County. That's definitely not true, right? I said, what do you mean you've never been anywhere? She says, I've never been out of the county. What? You've never been to Ocala? She says, no, I've never left the county. And I said, are you serious? And she says, yes, I've not. And then she stops and she backs up. She says, well, that's not entirely true. I was born in Brooksville, but I don't remember that. You've been in this county for almost 100 years and never left? She says, yeah. I says, oh my gosh, tell me what life was like. This is living history. She remembers when there were no paved roads. She remembers when the first car dealership came to town. She remembers the first McDonald's that opened. But most interestingly, she remembered the two families in Inverness that were like the Hatfields and the McCoys. And the daughter from one family was supposed to marry the son from the other family. And instead, she ran off with another guy. And what a soap opera that was. This is living history. When I left there, I called up my office. I'm like, send me back. I want this lady. This is amazing because this is the county I lived in. I'm learning things that you're not going to find anywhere else. This is interesting, right? So sometimes the people that think that they have nothing to offer are the ones that you will find the most interesting.
Really quick, I'm driving Lyft right now part-time just for extra money, and I met a lady, an elderly lady that was my rider that lived in St. Pete before the polio vaccination. And she
Wow.
told me, I wanted to talk to her more about the crisis of the polio, and that she was one of the people that didn't die from it.
Wow.
Didn't get like a major disability or anything. Because I guess St. Pete is the main area with polio, or
St. Pete had a big polio outbreak. Yeah.
yeah. And that was what, like 80, I don't know.
It would have been back in
Years ago?
probably the 40s, the 30s or 40s. Yeah. 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 I've met many people who spent their childhood in an iron lung because of polio. Yeah. Can you imagine? I mean, that to me is just heartbreaking that, you develop a disease, and in order to keep you alive, we put you in a metal tube and keep you there for years. I mean, talk about not having a childhood. Like, yeah, there's no playing ball. There's no video games. You're stuck in an iron tube for years. And that's just really heartbreaking. Very heartbreaking. Yeah, polio is a horrible disease. And what's worse, this is what okay, tangent guys. This is what a lot of people don't understand about viruses. And this is, I think that this should be talked about a little bit more, right? When we get a virus, we tend to think of the common cold, right? I sneeze, I cough, I get a little achy. A couple days later, I'm fine. I go about my life, right? We don't really think about viruses other than the symptoms that they cause from us. But a virus itself invades your cells, and it turns that cell into a copy machine, which keeps it from doing its own job. But the real problem is there are some viruses that don't ever leave. One of those is the chickenpox virus, the varicella virus, and it can go on later in life to cause shingles. That virus is living in your nerves. It's dormant, but it's still there and can be reactivated at any time. So that tells us that viruses have this capability. The polio virus was another one that did that. There was something called post-polio syndrome that tended to come up as you aged. And if you had the polio virus, then later in life, it could ramp back up and cause more symptoms. So it wasn't, okay, I got polio, I'm good, I overcame it, I'm fine. You always have this threat of it reactivating. Now, the problem is when we get new viruses, we have no idea if they have that capability or not. And we won't know. We won't know. Like COVID. That's right. We won't know until 30, 40, 50 years down the road whether this is a latent virus, which is one of the reasons that the public health community is like, we've got to keep this from spreading, because it's not just the now that we have to worry about, it's the potential future as well. And I don't think that the general public really understood that. I don't think that was communicated well. If you knew that if you got this virus, you might clear it when you're young. It might just cause some symptoms and you'd be okay. But there's a chance that if you got it and it lives in your body, it could reactivate in 20, 30, 40 years and cause some symptoms that we can't anticipate. We have no idea. We have no idea because COVID was an epithelial virus. And these cells are all over your body. They're in your heart. They're in your lungs. They're on the surface of all of your blood vessels. So you reactivate that when you're older, that could be just a horrible thing. I mean, chickenpox is bad enough. That's your nerves, right? You've got those everywhere, but they're not inside your organs. So, you know, I think that our public health really could use some help on communication with the public. I think that that's kind of the missing piece. But anyway, I digress. So, but yes, polio was, that's a very interesting story. And I'd love to have a conversation with that lady. But you never know what kind of conversations you're going to have. The point is you've got to have them. And feeding is the right time for that. Okay. You also need to sit when you're feeding a patient. Don't stand over somebody when you're feeding them. There's a power dynamic there. They're going to feel rushed. They're going to feel like you don't want to be there. They're going to feel like you're impatient and they're not going to eat well. There's a power dynamic there. You have to sit eye level and have a conversation. Good? Make sense?
So what are we supposed to do when the student, I mean, or even in real life when they do refuse?
We're going to talk about that in just 1 second. So for this skill, we're going to ask them to sit up straight to make sure they're in an upright position for feeding. We're going to offer a hand wipe and a clothing protector. Yes, I know the care plan says that they cannot feed themselves. It does not say they cannot use their hands. So if food starts to fall out of their mouth, what do you think they're going to do? Right? They're going to reach their hand up to their mouth. We don't want unclean hands at the patient's mouth. So we have to give them a hand wipe to be able to wipe their hands off in case they use them. But it's also because of ritual. And this is the part that we don't really think much about. Most of us have been trained to go wash your hands before eating. It's just kind of our ritual. And that's part of hand washing. If you give them a hand wipe or give them a way to wash their hands before you feed them, it can help stimulate the appetite. If you don't wash your hands before you eat, you should. You should. Right? Tangent?
So it's not part of the test that we
It
have to
is.
ensure that
No,
they-
you don't have to ensure, but you have to offer. You're also going to offer them a clothing protector. They don't have to use it. They can say, no, I'm fine. Me, I use clothing protector. Yeah, yes, I wear everything. Everything I eat, I end up wearing. Now, my grandmother, very prim and proper, you offer her a clothing protector and she'll tell you, I am not a child. Right? That's fine. Either way is fine, but we're going to offer. But here's a tangent for you. I'm a big cruiser. I was. I'm not so much anymore, but I've been on over 30 cruises. I love to cruise. And right after COVID, once they opened the cruising industry back up, we went on a cruise. And the one thing that I absolutely loved that COVID did is that it parked all of these ships for months and months and months and months. Well, while they were parked, not being utilized, they kind of updated some of them. And one of the things that they did is they put actual real hand washing stations near or at all food areas. Okay. So before they would stand there with the hand sanitizer and go washy, right? And hand, give you some hand sanitizer. Yes. And unfortunately, hand sanitizer doesn't, isn't optimal, right? But it's better than nothing, especially if you're going through the buffet line, get everybody to, at least kill the pathogens. They're still there, but they're dead. Well, now there's actual hand washing with real soap, real water, real paper towels, or dryer at each food station. So I'm thinking, awesome, because this is one of my big pet peeves about cruising and the buffet is that you watch people walk out of the pool area, go right into the line, and then touch all these utensils that I'm going to be touching, and that's a problem. So this is one of my pet peeves, right? So I'm thinking, yes, awesome. It's right there. Everybody will use it. It's super convenient. My husband and I were the only ones I ever saw using. So they installed them for me. Yay! Right? But we were the only ones that I saw using them. But what it did is it actually made it a little more convenient for us at the buffet, right? I'd wash my hands. We went and got our food. And then I put the food on the table, and it made it very convenient for me to go wash my hands before I actually started eating. So it really helped with that. But yeah, most people everybody should wash their hands before they eat, but most people don't. And this is how diseases spread on a cruise ship very, very quickly, very quickly. Wash your hands. All right. So we're going to sit when we feed the patient. We're going to offer a drink before and every 2 or 3 bites. Everybody drinks differently. Some people drink before a meal. Some people drink during a meal. Some people drink after a meal. We're just going to offer. They get to decide what they want to do. We're going to feed slowly. The spoon should only be half full. And we're going to have a conversation while we feed them. We're going to encourage intake. So remember I said, somebody just asked about this. Remember I said that they're only going to be told to take 4 bites, right? And then they're going to refuse. So what do we do then? What do we say? Well, there's 3 things that I want you to remember about encouraging a patient. You need to use 2 of them. I don't care which 2. The first is, are you sure you don't want just one more bite? You can get far with patients by being nice. And I am very sweet to my patients. I'm not always sweet. Ask my kids, they'll tell you. But to my patients, I am very sweet. And it's very hard to turn me down when I turn up the charm. Come on, Mrs. Jones, just one more bite for me, please. Come on, just one more. And most people I can get to take a few more bites. Okay, so be sweet. The second thing that you can do is offer them something different. Now, this is especially important if they only take a couple bites and they're like, nah. We've all had those days. We get something, we take a bite, and we're like, nope, not it. Not what I was looking for. It's just not hitting quite right. Right? We've all had those days. Well, you get to decide to go do something about it. Your patient that you're feeding, they're kind of stuck. So offer, can I get you something else? Is this just not working? Maybe a sandwich? Think they've got an alternate meal. You want me to try that? Right? We're going to try to encourage them to eat. What we don't want to do is go, oh, thank God, I've got a million things to do. You were holding me up. Right? We want to make them feel like we want to be there, that encouragement is part of this. Now, the last thing that I'll do, if I've got a patient who particularly is not eating well at all, the last thing I will do is remind them that we do have snacks available on the unit if they get hungry later. I don't want them to think that they have to starve if they get hungry later. So are you sure you don't want just one more bite? Okay, is there something else I can get for you from the kitchen? No? All right. If you get hungry later, just let me know. We do have snacks available. You need to use at least 2 of those. That gives the patient the feeling, whether it's true or not, I don't care. But it gives the patient the feeling that you are invested in their success. That you're not just checking off a box of a task that needs to be done. Your patients will respond to you a whole lot differently if they feel that you care about them. Okay? Does that answer your question? All right. Of course, leave the mouth clean, right? We've seen this before. We saw it with mouth care. We saw it with denture care. And we're going to see it again with feeding. We leave the mouth clean. So use the towel. We don't call it a bib. Use the clothing protector to wipe their face, or you can use a napkin to wipe their face, but make sure their face is clean at the end of this. Then you're going to do your closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Here's your call light. Bed's in the low position. Environment's clean. We're not going to open the curtain because we never closed it. We're going to go wash those hands. And then after we wash our hands, then we're going to document the intake. Now, the document, this is going to answer your question. The documenting of the intake, they only took 4 bites. Oh, okay. They only took 4 bites, and the spoon was only half full. So it's about 25%. Now, we're going to go over percentages in just a minute. Now, liquid for the test, you're feeding 25% is pretty much what you're going to be at. Okay. For the liquid, though, it really depends on your patient. They may not drink at all. In that case, it's 0. They may down that whole cup of water because they're getting ready to test and they're nervous and they got a dry mouth, right? So they may down that whole cup of water. In that case, it's 100%. We'll talk about the stuff in the middle in a minute. But you're going to base your fluid intake on what the patient actually drinks. Food intake for the test is probably going to be 25% because you're only filling that spoon half full. Good? Make sense? Okay, for this one, details matter. Details matter. You're going to sit while you feed them. You're going to offer a hand wipe before feeding, offer a clothing protector, offer a drink before feeding, and every 2 to 3 bites. Let them lead, feed slow, spoon only half full, and no childlike feeding techniques. No planes, trains, or automobiles. No race cars, no choo-choos. Because remember, this is demeaning. We never treat adults like children, right? So we're going to be professional about this. But I will tell you that in a clinical setting, there are some patients that I can have some fun with. Those that have really good sense of humor. And I have used these not in a demeaning way. I don't use this with dementia patients. But if I have an older gentleman that is a jokester, yeah, choo-choo train is, get them to smile. You have to really use some discernment here. Remember that we don't want to use this in a demeaning way. But I always try to inject a little humor in my practice. I think that it makes me more relatable to my patients. And it makes the whole thing more human. Help isn't help if it doesn't help. I want to be there to help them emotionally as well as physically. But I would not use this with my grandmother. Nope. All right, so let's talk about estimating percentages. For food intake, percentage is always estimated on a quarter scale. So if the tray isn't touched, if they eat nothing, it's 0%. They refused. If they ate everything, it's clean plate club, it's 100%. Now there's a little wiggle room here. If they took 1 bite, but they didn't eat like a quarter of the tray, then it's closer to 0. Okay. So even taking 1 or 2 bites might be closer to 0. If they ate everything but left some broccoli stalks behind, that's closer to 100%. So this isn't a scientific measurement. This is a guesstimation. Make sense? If they ate about half of the tray, well, you're going to give them credit for 50%, half. Make sense? Those are the easy ones. 0, 50, 100, those are the easy ones. It's the 25s that get a little murky. Okay, so 25% and 75% a little murky. So the best way to think about this is you've got 0, 50, and 100. If it's between 0 and 50, it's 25. If it's between 50 and 100, it's 75. Okay. You're not going to count each piece of Jell-O. You're not going to count every potato chip. It's an estimation. This is a broad stroke. And let me explain to you why we use this. As a nurse, if I've got a patient whose weight is falling, like we're on weekly weights, and for the last 4 weeks, my patient has lost 1 pound or 2 a week. I'm going to go look at their medications. Are they on anything that would cause that? If the medications don't leave me to any clues, I'm going to go to our meal record and I'm going to look down and see what has this patient's appetite been like. If I'm seeing on that meal record 75, 100, 75, 100, 100, 75, 100, there's a problem because they're eating most of their food and they're dropping weight. So something is probably going on internally with the patient that needs to be checked out. Now, on the other hand, if I go to the meal log and I see 25%, 50% refused, 25 refused, 50 refused, their appetite has changed. something is going on with my patient. Could be psychological, could be physical, but something is going on with that patient, and that needs assessment. These food percentages are just used to give us a quick overview of trends so we know how to address changes. Okay, nothing really scientific here. Now, there is a difference between this and fluid intake that is measured for intake and output, which we're going to talk about in about 5 minutes. Okay, so estimations is just a broad overview for trends. Measuring is scientific and has a much higher degree of accuracy. Make sense? Good. All right, so let's give this a try. This is what we start with. We have a sandwich, some broccoli, and some Jell-O. This is what the patient started with. We go pick up their tray and we get the first one back. How much did this patient eat? Yeah, they ate a whole stalk of broccoli. They ate quite a bit of the Jell-O. They took about 2 bites out of the sandwich. About 25%. Yeah, about 25%. What about this one? Yeah, pretty much 50% right down the middle. Half of the sandwich, half of the broccoli. Not quite half of the Jell-O, but close enough to call. What about this one?
75.
What about this one? Close enough to call. 100%. I don't think broccoli stalks count, personally. Just fiber.
Also, another reason they could not be eating is if the food was flat.
Oh, absolutely.
Like my great aunt is close to that. She hates food.
Absolutely. I actually worked for a facility that had a 5-star chef. Amazing food. Amazing food. There was a wait list to get into that place. Yeah. And then, yeah, I mean, as a culture, we put a lot of emphasis on our food, you know. But most of the places I've worked at is all institutional food. It's horrible. I don't blame them. I wouldn't eat either. Yeah. All right. So now we're going to talk about intake and output. This is different. Intake and output is measured. So when you're documenting, you need to know, am I on a quarter scale or am I on intake and output? Because those are two different things. Quarter scale means they took a couple sips of their water. We give them credit for 25%. General overview trends. Intake and output is measured, and we have to do this scientifically because there are certain conditions that my patient may have where I have to make sure that fluid in is very close to fluid out. Otherwise, they're either holding fluid, it's got to go somewhere, or they're shedding too much fluid. And in that case, they may get dehydrated. So we have to, in some cases, keep track of how much fluid goes in and how much fluid comes out. And hopefully we are at close to a balance there. Otherwise, there's a problem. So in that case, we're measuring things. And when we measure things, it gets a little bit dicey, okay? Because here in America, we measure everything in ounces. But in medicine, we measure everything in mLs. You'll also see it as cc's. mL, cc's, the same thing, okay, for our purposes. I know, don't come at me, YouTube. mLs is fluid, cc's is volume. We're using them interchangeably, but scientific people on my YouTube page will tell me they're not exactly the same. I know. For our purposes, they are. Okay, mLs and cc's, same thing for our purposes. So if we have a cup, that cup right there, and I know that cup is 8 ounces, that doesn't help me when it comes to documenting intake because I have to document in mLs or cc's. So 8 ounces, that doesn't help. I've got to convert that. The way that we convert it is we multiply the amount of ounces by 30. So 8 ounces, I would multiply by 30. So 8 times 30, and I would get 240. and I would document 240 mLs or cc's. Now, if the patient has a packaged item, like that Dr. Pepper can over there, if you look at the bottom of that can, it's going to tell you how many ounces. Okay, well, tell me the ounces. 12. And next to it, in parentheses, is going to be the amount of mLs. How many mLs? 355. Okay, so notice those are different. So 12 ounces, if we multiply that by 30, would have gotten us 360. But the can says, what does can say? How many mLs? 355. So 12 ounces, it's not a true 12 ounces. Okay. It's 355 mLs, which is a much more scientific calculation. Which one do you think I should use if I'm looking at a prepackaged item? Should I use the 12 ounces and do the math myself, or should I use the mLs that are provided on the item? Which one do you think is more accurate? The provided one, that's right. So if we have a packaged item where the mLs are provided on the package, we use that. In the absence of that, we take the ounces and multiply them out. Okay. Now, every packaged liquid has the mLs already provided. So look at that water bottle. If you look at the volume on it, it should say 15.9 ounces, right? Or I'm sorry, 16.9 ounces and 500 mLs. So which one would I use? Yep.
So how do you know what to multiply it by?
30. So 1 ounce equals 30 cc's. So you look at the ounces, you multiply that by 30 to get your mLs. So if I have an 8-ounce cup of water, I multiply the 8 by 30 and get 240. If I have a 12-ounce or 6-ounce cup of coffee, I multiply the 6 by 30 and get 180.
How do we know how many ounces? Like, oh, that's a mug. How would we know?
So when you go, that's a very good question. When you go to work, wherever you go to work, you're going to have an orientation. Orientation's a couple days, usually like in a conference room. They're going to tell you where to park, how to get your insurance, what their policies and procedures are, where you're going to be working, dress code, all of that, right? And then you're going to have a clinical orientation. And part of the clinical orientation for CNAs is they're going to tell you, okay, this is our coffee cups. Our coffee cups are 6 ounces. This is our water cup. Our water cups are 8 ounces. This is our whatever, it's this amount of ounces. So you will know that when you start work. And that's part of your orientation. A lot of CNAs just kind of glaze over that. They don't really pay attention to it. And then they start to work and they're like, oh my gosh, how many ounces is the coffee cup? You can ask your nurse or another CNA, somebody there knows. If all else fails, I'll call down to dietary. What size are our coffee cups? Because dietary has to know that. What size are our coffee cups? What size are our juice cups? And they'll be able to tell us that. Okay.
And even if it's like a percentage, like the 16.9, it's still going to be times by 30.
Right. Right. Which is a whole lot of math I don't want to do. So I'm going to use the 500 mLs that's provided for me. Okay. Good. Make sense? And sometimes we're going to have to estimate this. I never drink a full cup of coffee. I don't think I've ever seen the bottom of a coffee cup. I don't drink a full cup of coffee. I like my coffee with lots of cream and lots of sugar, right? So little coffee in there. But I drink about half. So if my cup is 6 ounces and I'm only drinking half of it, how many mLs did I take in? 90. That's right. That's right. So this is going to require a hybrid of estimation and calculation. Make sense? Good.
Is that going to be on the scales portion? Like on the set? Just for measuring?
Yes, but not for this skill. We're going to learn one on Monday, emptying the urinary drainage bag, and that we're going to empty into a cup, a very specific cup that has ounces, but it also has cc's. So which side would we use when we're measuring? Cc's. Good. So yes, we are going to have an I&O measuring activity for the skills exam, but not for food. Food is just a quarter scale estimation. But you need to know this because this will be on the written exam. We multiply our ounces by 30. So if you look on page 106 of your book, this is an activity for you to be able to put this into practice. Now you can do the food estimation on your own. I want to come down to this section here at the bottom of the second column. We have 6 ounces of juice. So how many cc's or mLs would that be? 180. So let's write 180 in that spot. 180. Now next to it is a milk carton. And the milk carton, it actually tells us how many mLs. So we always go by the package. So write 240 underneath. You can just write the numbers, it's fine. And then you have coffee, 12 ounces. That's a big cup of coffee. And the patient drank all of it. So how many mLs are we going to write in there? 12 times 30 is 360. Now, at the end of your shift, you have to add all of this up and get a total. So if we're going to add 180 plus 240 plus 360, can anybody do that math? 780. So the total intake for the shift would be 780 mLs. Now, the thing to remember about intake and output, and this is super important for you to understand, you are not the only one measuring this. You are responsible for things that go in the patient's mouth and come out from below. Okay? That's what you are responsible for. So if it goes in the mouth, you're recording it. If it comes out from below, you're recording it. Other things are going to be recorded by the nurse. So IV fluids, wound irrigation, wound drainage, things in like chest tubes, drainage. So the nurse is going to be documenting other types of fluids that go in or come out of the patient as well. And that's what, all together, we're going to hope that they are pretty close to one another. So CNAs are responsible for things that go in the mouth and come out from below, but you're not the only one that's documenting intake and output. Okay, good. Good.
Would it be on our care plan if we were doing that?
That's exactly where we're going to find it. Is it'll actually say on the care plan, patient is on intake and output measurements. That's also something you need to know during a report. So when you go to work in the morning or in the afternoon or whatever your shift is, when you report to work, you're going to get information from the off-going CNA. So the one that's leaving, done with their shift, they're going to give you information. Okay, bed 1, fine, walkie-talkie, doesn't do anything. You don't need to do anything with him. Just remind him to go to the dining room because he's a little forgetful. Bed 2, she is confused. She needs a lot of redirection. She goes in and out of other people's rooms. So make sure you keep an eye on her because she'll go where you don't want her to go. Bed 3 is on intake and output. We're measuring everything on that patient. Bed 4 is incontinent. You've got to turn and change every 2 hours around the clock. So you're going to get this report, and intake and output will be one of the things that is passed along to you. Okay? Good? All right. Page 132 has a list of medical abbreviations. You don't need to memorize all of these, but you should have some familiarity with most of them. The ones that are highlighted, those you do need to know. And I want to go over a couple of these because they're not intuitive. You have to understand that most medical abbreviations are abbreviated Latin, not English. They're not going to make sense to you in English. QD, how does that mean every day? It's because it's Latin. Quacquedia, I think it is. My Latin is very rusty. Is what it's abbreviated from. So when you're looking at a lot of these, it doesn't make sense in English. BID, why is that twice a day? TID, why is that 3 times a day? So let me demystify this for you. B stands for bi. How many wheels are on a bicycle? 2. So this is 2 times in a day. BID is 2 times in a day, twice a day. T stands for tri. How many wheels are on a tricycle? 3. Guys, tri is Latin. You already know it. Bi is Latin. You already know it. A bicycle is 2 wheels. It's a Latin word. We just think it's American. It's not. It's a Latin word. Bicycle, 2 wheels. Tricycle, 3 wheels. Triangle, 3 angles. They're Latin words. We just don't really see them as Latin. QH is every hour. And QHS is every hour of sleep or bedtime. It's somni. I say sleep, but somni is the word, the Latin word for it. So QHS is every bedtime. I know it doesn't make sense in English, so don't try to make it make sense in English. Now, if you go down, way down here, I've got NPO, which again is Latin. NPO means nothing by mouth. Nothing by mouth. You need to know that. If you don't know anything else on this, you need to know that one. NPO is nothing by mouth. But all of the ones that are highlighted there, you probably should have some familiarity with. This is a whole activity. So the next page, page 133, is an activity related to this. Helps you put into practice how all of these are going to be used. Once you do that activity, they start to become a little bit easier to understand because you're putting them in perspective. All right, page 169 we talked about. That's the intake and output sheet. So the food sheet we already looked at. The intake and output sheet, which we will use for urinary drainage bag, is on that same page as well. I have a whole lesson on intake and output on page 107 if you want to learn more. What happened? Hold on. Okay. There we go. All right. So that's what we need to know about feeding. So if we use all of those principles to check these off, we're going to follow that care plan. We're going to do our opening. We're going to evaluate if we need gloves. Let's talk about gloves for a second with feeding. If your patient is holding on to all of their own body fluids, you do not need gloves. You should not wear gloves for feeding a patient unless you need them. Gloves give off an odor. That odor is an appetite suppressant. When you put a glove right underneath somebody's nose, they're smelling the glove and it'll actually kill their appetite. So wear gloves if you need them. If the patient can't hold on to their own body fluids, that's fine. Wear gloves. But if you don't need them, if you're at the other end of a spoon, don't wear gloves. Okay. Linen rules apply. Don't hold them against your uniform. Nothing goes on the floor. We're going to feed our patient using those same checkpoints we just talked about, and then we're going to do our closing. This is a documentation skill, so we do have to document. So we're going to put all of those steps together to make this particular skill. And remember, this care plan is only for that patient, not for any of these. And we're going to watch the video. Video is like 3 minutes. Remember, they give us, what, 9 to do this? Or 11? I think this is 11. Yep. Take her away. Good afternoon, Mr. Jones. My name is Patty. I'm your CNA today. Could I ask you to sit up straight before we get started, please? How are you?
I'm good.
Fantastic. Would you like to eat a snack?
Yes, that'd be lovely.
Okay, I'd be happy to help you with that. Let me go wash my hands, get my supplies, and I'll be right back. Okay, Mr. Jones, I'll give you a hand wipe so you can clean your hands before we feed you. Okay, would you like to take the hand wipe?
Yes, please. Thank you.
And go ahead and clean your hands. Thank you very much. I'll dispose of this in the trash. And would you like a clothing protector?
Yes, please.
I'm going to go get one for you. Okay, Mr. Jones, I'm going to take this clothing protector and put it over your chest. This will just protect your clothing while I feed you. And I'm going to pull up a chair. How are you doing today?
Very good.
Wonderful. Would you like a sip of water?
Yes, please.
Okay. And we have cinnamon applesauce. How does that sound?
Great.
Wonderful. Here we go. We're going to fill the spoon less than half full. And do you enjoy sports?
Yes.
What sport do you like?
Football.
Oh, I do too. Did you watch the big game
I
yesterday?
was so happy my team won.
Oh, it was such a great game. I couldn't believe in that last quarter what happened. Another bite?
Yes, please.
There you go. Would you like a drink?
Yes, please.
Okay. Good?
Yes.
All right. Yeah, my favorite team doesn't win very often. Usually when I'm watching, they're guaranteed to lose.
Usually for me as well.
Would you like another bite?
No, thank you.
Are you sure?
Yes.
Okay. Can I get you something else from the kitchen?
No, thank you.
Okay, if you get hungry later, please let me know.
I will.
Okay. All right, I'm just going to take this clothing protector off. And we'll clean your face. I'm going to put this in dirty linen. I'm going to dispose of all the disposables. And we'll return the tray to the bedside table. Just going to move this to the side. And are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Let me get your call light for you. There's your call light. If you need anything at all, just hit that red button. We'll be happy to come help. I'm going to go wash my hands and document. After washing my hands, I'll document the amount of food the patient ate and the amount of fluid that they drank. Once I'm done documenting, I'm going to go wash my hands one final time. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done. Okay, before we get into our next skill, which is Peri-Care, I want to go over respirations really quickly. Now, I don't have anything on the screen for that because it was in a previous, I can't find the slides. You know, it would take too long to find the slides. So I'm going to do this verbally, okay? So in your skills book, turn to page 54, please. So if you look down the side, you'll see that we know all of the principles here. We just have to learn our test-specific steps for this skill. And I'm going to go through those pretty quickly here. When we're counting respirations, we don't want to tell our patient we're counting their breathing. I don't want to say, I'm going to count your breathing, ready, set, go, right? Because now you're aware of your breathing. We're not going to get an accurate reading. So we say vital signs instead. I'm going to take your vital signs. We're not lying. Respirations are vital signs. They're one part of, but you just don't want to bring attention to what you're actually counting here. Your patient's going to be laying in bed for this skill, which makes visualizing the chest rise a whole lot easier. It's easier to count somebody's respirations when they're laying down versus when they're sitting up. So the test really presents this in the easiest possible light. In and out count as one. So that was one breath. That was another breath. So in and out counts as one, that whole cycle. Good. Normal is between 12 and 20. Now, when you're looking at this skill, it actually looks from the outside like you're taking the pulse. We're going to count for 1 minute because that's what our care plan tells us to do on page 55. Care plan at the top of the page says to count the patient's respirations for 1 full minute and record our readings. So we're going to count for 1 full minute. So it's going to kind of remind you a lot of the pulse. Now, the other reason it's going to remind you of the pulse is because I'm going to make it look like I'm taking the pulse. Here's the problem. This is, I want you to kind of imagine you're the patient here for a second. If I come up and do this, okay, ready, go. How awkward is that? You're staring at your patient's chest and you're not saying anything and you're not touching them. You're just silent, staring at a patient's chest. That's awkward. We don't do that. So for this skill, I'm going to tell the patient, I'm going to take your vital signs. Is that okay? Close curtain, wash hands. I'm going to come over here and I'm going to lift the arm, keeping the elbow on the bed, just like I was taking the pulse, and I'm going to hold their wrist. I did not find I'm holding their hand, essentially is what I'm doing. I didn't find the pulse. I'm not counting the pulse. My focus is here, watching the chest rise. But my patient's focus is here. It makes it more comfortable for the patient. If you make your patient anxious, what do you think anxiety does to heart rate and breathing? Makes it go up. So we want to normalize this as much as possible for our patient. We don't want them to feel anxious because that's going to make our reading incorrect, inaccurate. Make sense? Okay. So for this skill, oh, I don't have it up there. For this skill, we're not going to tell them that we're counting the respirations. In and out counts as one. You're going to make it look like you're taking the pulse, but you're not actually. And there's a little cheat that you can actually use for this skill that's really cool. It'll help you see the respirations a whole lot easier. So it helps you count them. But more importantly, it makes it easier for the evaluators to see from across the room. If you look at somebody's chest rising when they're breathing, it's not very big. It's hard to see. It's a small motion. But if you put an alcohol pad when they're laying down, put an alcohol pad on their tummy, as they breathe, you can see that pad move because it's all psychology. I'm not changing the breathing. It's what I'm doing is changing your ability to see the breathing through psychology because your attention is drawn to movement when it's a contrasting color. It's what kept us safe from the saber-toothed tigers running through the jungles. Okay, your attention is drawn to movement when it's a contrasting color. And you can use that on the state exam. So I'm going to put an alcohol pad on the tummy. My patient's probably not going to ask. And that's a neat thing about alcohol pads. Patients assume that you need them for something in medical. They don't really ask about them. And if they do ask, you can give them a non-answer, like I need that for later. And they'll go, okay, it's the weirdest thing. But your patients don't really press you with alcohol pads. Now, if you used anything else, if I put anything else on her tummy, she's going to have a million questions. Why is that there? What are you going to use it for? Is that going to hurt? They'll have a million questions. But alcohol pads are funny. They'll let us get away with this. The other reason I like alcohol pads is it's light. It's not going to interfere with their breathing, and it's disposable. I just throw it away when I'm done. Okay. You can use that on the state exam. Good? Good. No, I'm just going to put it right on top of the cover. Yep. Yep. Perfectly okay. The larger the body, the easier it is to see. Smaller bodies are a little harder to pick up. Smaller bodies also tend to breathe faster. So normal is between 12 and 20. Okay, this is a documentation skill, so we have to document the reading. So we would use that documentation form on page 168 of your book to document the respirations. Now I'm going to show you the video. Actually, Jake's going to pull up the video for this. And on the video, do you remember when we watched the video for pulse and I had on the bottom of the screen the letters that got bigger and smaller for you to be able to count along? Well, this one you'll also be able to count along. So when I say start out loud, how long am I counting for? 1 full minute. So when I say start out loud, count the respirations with me. So in and out, count as 1. Count the respirations with me. And then at the end, see if you got the same number that I document. Okay, good? All right, Jake.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to get your vital signs. Is that okay?
Yes.
I'm going to close your curtain. Let me go wash my hands and I'll be right back. Okay, Mr. Jones, I'm just going to lay this on your stomach for later. I'm going to elevate your forearm, keeping your elbow on the bed. And this will take me about a minute. I'll need you to remain quiet during that time, but I'll let you know as soon as I'm done, okay? And we're going to start. Ready, set, start. Stop. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Okay, bed's in the low position. The environment is clean. Here's your call light. If you need anything at all, just press that red button. We'll be happy to help you. I'm going to go ahead and open the curtain and throw my alcohol pad away and wash my hands. After washing my hands, I'm going to document on the sheet provided by the evaluator and then wash my hands again. After washing my hands a final time, I'm going to review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. Really easy. That's why I wasn't too stressed when we didn't get to it the other day. All right, moving on. We have Peri-Care. Go to page 152 in your book, please. All right, there is absolutely nothing new to learn here. You know everything you need to know to do Peri-Care. Everything you need to know to do Peri-Care. But I have to put the pieces together for you. Okay, so that's what we're going to do now. If you look down the side, you'll see that we know all of those principles. They're all spelled out for us here. Yeah, we're going to use almost all of them. We're going to follow the care plan. We're going to do our opening. We're going to use a barrier. Yes, you need gloves for this. We need a privacy blanket. Linen rules apply. Keep the patient in the middle of the bed. It's a washing skill. We got to clean the basin, and we got to do our closing. We know all of those steps, though. Nothing new here. Down at the bottom, you'll see our test-specific information. Somebody with your level of experience should be able to do this in 17 minutes. It is going to be done on a mannequin. This is a mannequin skill. You still have to talk to the mannequin like it was a real person. And the evaluator will hold the mannequin on their side for you to do your cleaning. So you will get a little bit of help from the evaluator for this. Real people can lay on their sides, no problem. Mannequins can't. All right, mannequin will be on a bed, and charting is not required for this. Your care plan and step-by-step instructions are on page 153, along with your supplies. There are a lot of supplies for this skill. You have to learn them. But let's take a look at that care plan. It says the female patient has been incontinent of urine and needs perineal care. The pad under the resident is wet, but the hospital gown and bedding is dry. That's a miracle. Never happens. Never happens. But take the gift they're giving you for the test. In reality, the pad is going to be dry. They're not going to wet the pad. They're not going to do anything crazy like that. Our care plan is telling us it's wet. We're just going to go with that. Okay? Good so far? All right. So we know all of these principles, but we need to learn our test-specific or skill-specific steps, and that's what we're going to focus on right now. But before I get to that, we have to learn a little bit about what incontinence actually is and what it's not. So in order to find this out, we have to go way back to 5th grade. Bless you. And review anatomy. Now, again, this is 5th grade anatomy. Everything is way more complex than I'm going to make it out to be, but we have 2 kidneys. Those kidneys filter blood and remove impurities and make urine out of those impurities. That's what kidneys do. They're a big filter system, but they run 24 hours a day. Your kidneys never stop working. They don't get vacations. They don't get coffee breaks. They're always working. And when they work, they produce urine in drops. So this kidney is working, took out some impurities and made a drop of urine out of it. That drop falls down a tube into a bladder. And the bladder just holds all of these drops. So both of these kidneys are working overtime. Drop, 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 and all those drops accumulate in the bladder. What keeps them in the bladder is this guy down here, a valve. There's a valve at the base of your bladder that closes. It stays closed unless you open it. That's what it does. Okay? That valve closed allows this urine to build up in your bladder. And eventually your bladder gets full. A bell rings in your brain, says, hey, go find us a bathroom. We're full. You go find a bathroom and you open that valve and the urine comes out. After you urinate, you close that valve again and the whole system starts over. Good? Questions? Got this? When a patient is incontinent, this whole system still works. What breaks is the valve. So the kidneys still filter blood 24 hours a day. Those drips still go down tubes into the bladder 24 hours a day. The problem here is that the valve doesn't keep the urine in the bladder, so those drips come right out of the body. This means that your incontinent patient is going to be wet all the time. Drip, 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 drip. If you have a patient who is dry, 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 really, really, really wet, that is not an incontinent patient. That valve held that urine. Your patient is not incontinent. What I have are incompetent staff members that aren't taking my patient to the bathroom. Okay, so our incontinent patients have to be changed every 2 hours around the clock, at 2 a.m., at 4 a.m., at 6 a.m., at 8 a.m., every 2 hours around the clock. And if I have a CNA that tells me, oh, the patient was dry, she didn't need to be changed, I'm going to let that patient or that CNA go because you just lied to me. And you aren't taking care of my patients. And I am the one legally responsible for that. So I'm going to do everything in my power to get rid of you. Got it? This is how we end up with CNA versus nurse. Because I will be out for you. Not because I'm mad at, or not because I have something against you. It's because you're unethical and you're taking care of my patients. And if you're willing to lie to my face about this, what are you hiding from me? You guys see that? So when we have a patient who is incontinent, it's this part right here that we have a problem with. But there's good news because this is a muscle like other muscles in the body. And if I'm sitting on the couch not doing a whole lot, my muscles are going to get flabby. They're not going to work real well. They're going to degrade. They get some atrophy going on, right? Nothing's working all that great. But if I get up off that couch and I start to move and I start to exercise, my muscles get stronger. And we can do the same thing with this muscle. We can put our patient on a toileting schedule, which means that every 2 hours, you're going to take that patient to the bathroom and you're going to put them on the toilet. And we're going to wait to see what happens. And then we'll clean them up and we'll try again 2 hours later. And we'll try again 2 hours later. And we'll try again 2 hours later. And after a couple of days, the body starts to get on board with this. And it starts to understand what we need to do here. And that muscle, every time the patient is on the toilet, that muscle relaxes, but it also learns how to tighten back up again because of that repetition. And we can help our patients become continent again through a toileting schedule. So one of the questions that you might see if you guys can get this. The care plan assigned you to toilet a patient every 2 hours around the clock. You go in and the patient says, I don't have to go to the bathroom. What should you do?
Let's give it a try.
Yep, we're going to follow the care plan. Yep, follow the care plan. So remember, if you see that word assigned, the rest of it doesn't matter. The fact that the patient says, I don't have to go to the bathroom, doesn't matter. Get rid of that statement. Does not have any bearing here. Good? Now you know how to answer one of the questions on the test. But it goes a step beyond that. Even though the patient may not feel like they have to go, we're trying to work out this muscle. So the fact that the patient says, I don't have to go to the bathroom, that's irrelevant. That's not why I'm not here because you have to go. I'm here because we're exercising a muscle. So don't skip. Okay, good. You're starting to see that there's always something about this that you just don't know. Like if I tell you to toilet a patient every 2 hours, you think it's so that they can go to the bathroom. No, it's because I'm trying to train a muscle. There's something there that you don't know. That's why we have to follow these rules. Because if I have to explain every decision I make to you, we're not going to get anything done. Okay. So let's talk about this. If our patient is always wet because of incontinence, drip, 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 that poses a really big problem for our patient because adult urine is not like baby urine. Babies, you can put a diaper on their little tushes. You put them to bed, let them sleep 8 hours. They wake up and you take the diaper off. They still have skin on those little tushes. It's great. And that's because the urine that sat against that skin all night long was very mild, neutral, because our urine acidity is based entirely on what we eat. Babies don't eat a lot of acid. What they eat is actually very bland, whether it's breast milk or formula or cereal or baby food. It's designed to be very bland, not acidic at all. So their urine is very bland, very neutral. Adults, man, we eat acid like it's going out of style. Does, yes, medication is going to have a big impact on this as well. Also, another that I'm not getting too deep into this. I'm really kind of trying to keep it simple, but another aspect of this is cell disposal, because in our bodies, your cells are always being broken down and new ones are being reproduced, right? But as we get older, we lose more cells than we create. This creates kind of an imbalance, but each one of those cells has acid inside. As we reclaim the cells, it goes to the liver, they get broken apart. That acid that's inside the cell has to be excreted. So just by virtue of age, we're going to have more acid in our urine as well. Okay, make sense? Good. All right. So if we have an older patient who's incontinent, that urine is not good for the skin. And this is why we have to do this every 2 hours around the clock. We're not going to put an adult brief. We don't call them diapers. Not going to put an adult brief on somebody, put them in bed, let them sleep all night. Now, this is where CNAs kind of go wrong, because a lot of CNAs have a great heart, right? I don't want to wake Miss Mary up at 2 a.m. She hasn't had any good sleep. She's been so tired lately. I'm just going to let her sleep. Right? We have a big heart. Our heart's in the right place. The problem is that the acid is in the wrong place. And you're leaving that acid against the skin for 4 hours. What do you think acid does to skin? It eats it. That's right. So 4 hours go by, we go in to change Miss Mary, and now she's got a huge sore. She's not going to sleep for the next 3 months. Thanks. Make sense? Don't make decisions for your patients. You might have the best intentions at heart, but you don't know the actual consequences of your actions. And your patient's the one that's going to have to pay. Now, these guys are not diapers. They might look like diapers, but they're not diapers. For adults, they are adult briefs or depends. We don't call them diapers. But the problem with these things is that they're waterproof. They're designed to be waterproof. And that means they're going to hold in moisture. They're going to block out light, and they're going to hold in heat. So we end up with a warm, dark, moist environment. What grows there? Pathogens. Yeah. This patient who's incontinent and in a brief all the time is at risk for all kinds of infections, whether they're urinary infections, skin infections, yeast infections, all kinds of infections. This is not a good solution. It's okay when the patient's out of bed because nobody wants to wet themselves, right? This is a dignity issue. So when they're out of bed, we'll use it. We're still going to clean them and change them every 2 hours. Don't skip that. But there is a better way when they're in bed. This isn't used for everybody. The nurse is going to determine who we're going to use this on and who we're not. There's a whole complex list of things I have to go through as a nurse to figure this out. But in some patients, we are going to leave them open to air when they're in bed. Now, that means there's no undergarments. They're laying on a pad, and that urine that's kind of comes out onto the pad, which is then pulled away from the skin. It allows light and air to circulate. So we have fewer infection risks with open to air than we do with an adult brief. Now, like I said, this isn't used for everybody, but when our patient is open to air, we need to acknowledge that. We need to adhere to that. Good? This has a lot of benefits to your patient. And this is the premise that we're starting with for this skill. Our patient is laying in bed, open to air on a pad, and that's what we're going to go in and do Peri-Care on. We're going to change the pad because we got a wet butt on a wet pad, and that's not very comfortable. We'll talk about that in a minute. We're going to change that pad. We're going to clean the skin, and then we're going to change the pad again so we have a clean butt on a clean pad. Good? Okay, so let's think about that incontinence pad under the patient for a second. We learned last week that room temperature always wins. Now, urine, when it comes out of the body, is a little bit warm. It's somewhere around 101 degrees, roughly, because it's made up in our furnace area. So it's a little warmer than body temperature. So around 101 degrees as it comes out. So we have 101 degree urine spreading out on a pad, hitting 75-degree air. And room temperature always wins. Now, has anybody ever gone to the springs to swim? Anybody ever dip your toe in the springs? What is the water like? Okay, it is, say it loud. 72 degrees. All spring water is 72 degrees, which is not much different than room temperature at 75, right? I have a pool. I have to wait until because I don't have a heater, I have to wait till my pool hits at least 75 before my butt goes in it because it's just too cold otherwise, okay? So liquid at 75 degrees room temperature, we interpret as cold. So we have 101 degree urine coming out of the body, spreading out, hitting 75-degree air. That liquid is going to cool down to 75. What is that going to feel like to your patient? Cold. Yeah, that pad is cold, wet, and slimy. That's what it feels like. So when you go in to change that pad, your patient feels like it's cold, wet, and slimy. What's the first thing they want done? Change that pad. Step one, Peri-Care, change the pad. And this is why, because of the patient's perception, how they feel. We're trying to get them comfortable. So step one, change the pad. And we already know how to do this. Do you guys remember? Let me go back here. That's weird. Got some freaky stuff going on here. Check my aura. Is it okay? Okay. Yeah. That's okay. I can still talk. They don't need to see me for this. All right. So, right. So we already know how to do this. Anything that goes under the patient, we have a process for. Clean rolls toward me, dirty rolls away, right? So we're going to get our patient on their side. We're going to roll the clean one toward us before we put it on the bed. Roll the dirty one away from us. We'll tuck the clean under the dirty, and we'll go around to the other side of the bed and repeat the process. So it's just like the sheet, but smaller. We already know how to do this. Like I said, you know all the pieces to this skill. You just don't know you know them yet. Good? Good? One of the other things that you know is this. Using the leaves method. Remember that we have to use the leaves method anytime we're washing a wet body opening. Well, this is definitely a wet body opening. So we're going to use that same leaves method. So to remind you of what that leaves method is, we're going to change the chucks from under the patient. And then we're going to use that leaves method. So I have my plain square washcloth folded in half and folded in half again, held in a diamond shape with the free ends at the top. Tuck one corner in, the other corner in, and now I have control of my washcloth. So to do Peri-Care, we always wash away from the urethra, which is front to back. So I'm going to wash down the middle, pull away, and fold that over. The second leaf washes down the outside on one side. I'm going to fold that over. The third leaf washes down the outside on the other side. I'm going to fold that over. The fourth leaf is going to wash this crease between the leg and the groin, this crease, down, fold that over, and down. Okay? So middle, side, side, skin fold, skin fold. I don't know.
Trying to get it back up and running, not getting it to this point.
Maybe, oh, there, it's doing something now.
I'm resetting it again. I think
Yeah.
maybe something in the transmute table.
Okay. All right, well, I'm going to keep going. You can hear the lecture anyway. All right. So we know that whatever we wash, we rinse the exact same way. So I get my second washcloth, I wring it out really well, I hold it in that diamond shape, and I rinse down the middle, fold that over, down one side, top to bottom, fold that over, down the other side, top to bottom, fold that over, skin fold that over, skin fold.
I think that completely flaked out. Did you put some kind of soap on it? the first
So
time?
for the first time to wash, we put soap on it. For rinse, no soap. I don't think I said soap. Yeah, I just said wash. No, it's okay. I don't think I specified soap. So yes, you're going to soap each one of those leaves. Each one. Okay, so when you're going down the middle, now this is the important part right here, okay? So when you're going down, don't ever move back up. It's very, very important because what we're doing is introducing bacteria from the rectal area up to the urethra. So it's a one-way trip down and then move away. Very important. And a lot of students in the test, because you're nervous and you're just trying to get through, a lot of students will go down and then back up without even really thinking about it. We have to think about that. Don't do that. It's top to bottom, move away, fold it over. 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 Top to bottom, done.
I'm being anal now, probably. It's a completely different type of soap than what we clean the body with.
No, same soap.
Oh,
Same soap.
putting it in
Yeah, it's same soap. The soap is pH balanced for the entire body. Okay. In fact, most soap used in a clinical setting is actually called peri-wash, perineal wash. And we just use it on the whole body because it's pH balanced for everything. Yeah, we don't have to have a separate soap.
What, like, position?
Patients on their back. And if you have somebody who is quite large, you may have to have them spread their legs a little bit, bend at the knees, like we call it frog leg. But for most people, the majority of people, you should just be able to access it.
And for like the privacy blanket, it's still gonna be.
Right. So when we put the privacy blanket on, okay, we put it on over the sheet. And I think I have a slide for this, but we put it on over the sheet. We pull the sheet down underneath to about the knees because we need to open up the area that we're working on. And then I should have a slide on this somewhere. But then we're going to expose the area that we're going to work on. Now, let me show you something really quick on this. I'll do this on the mannequin. Jake, if we're working here, can you zoom over to me? So on this mannequin, I'm going to spread the blanket out over the sheet. Just pretend that red blanket isn't there. And I'm going to pull the sheet down to about the knees. Okay. Good. Now I'm going to get all of my stuff ready, do all my prep work, get my gloves on. So pretend I've got some gloves on. And now I'm getting ready to I've changed the pad out from under her, and now I'm getting ready to wash. Now I've got to expose her. There's no way around it. We have to expose her to do Peri-Care. But there's a big difference in how we expose her. So if I just grab the blanket and the gown and pull it up like this, right? That's uncomfortable for everybody. That's like really uncomfortable for everybody. So there's a better way. Instead of doing that, I've got the blanket on over the gown. Grab one of these. What I'm going to do is take that blanket and roll the gown up inside the blanket. And I'm going to roll it up just above the peri area. And then I'm going to take the towel and lay it over the leg. So the only area that's exposed is where I'm working. This is way different than that. Right? Make sense? So yes, we are going to expose our patient, but we're going to do it in a way that's less intrusive, more clinical. Good? All right, so whatever we wash, we rinse. Whatever we rinse, we dry. Always go top to bottom. So it's inner labia, outer, skin fold. Never move back up. And remember that they have to be in the middle of the bed. So I have to wash the front and the back of the patient. Remember, her butt's been laying on this wet pad. I got to get the urine off of that skin. So I'm going to turn her on her side to wash the back side. I don't just want to flip her on her side where she's close to the edge of the bed. I'm going to scoot her toward me, roll her up on her side, and then I'm going to clean her back side. Now her back side, we're still going to use that same leaves method. So I'm going to get my washcloth, wring it out, soap 4 corners this time, not 5, 4. And I'm going to use the leaves method. So I've got my washcloth that has soap on it on my hand, tucking in the side corners. And let me put it in this hand just so you can see. And I'm going to start at the anal opening and go up the center crease. And then I'll fold that over. This second leaf is going to wash that buttocks. Fold it over. The third leaf washes this cheek. Fold it over. And the last leaf is going to go right up that middle again because it's kind of like a riverbed. All the urine runs through there. And then I'll set that aside. Whatever I wash, I rinse the same way. So I'll take the 4th washcloth, wring it out, up the middle, one cheek, the other cheek, up the middle, set it aside. And whatever I rinse, I dry. So I'll dry the butt. Yep, same leaves method for rinse. So everything we wash, we rinse the same way. So we do exactly the same thing, just without soap. Exactly the same. Now that I've got a clean butt, I need a clean pad to put that butt on. So I'm going to change that pad. While I've got her on her side, I'll change that pad again. So now I got a clean butt on a clean pad. And we're good for another, how many hours? 2 hours.
Okay, so we cleaned the front area before they're still laying on the wet, cold.
No, we changed the pad. So let me go through this. We changed the pad. We exposed the patient. We cleaned the front, middle, side, skin fold. 5 leaves, each one soaped. Set that aside. We get our second washcloth, rinse it, middle, side, skin fold with each leaf. Set that aside, and then you dry top to bottom, just pat dry. Scoot the patient towards you, turn them up on their side. Washcloth number 3, wring it out, soap 4 corners, up the center crease, fold it, cheek, fold it, cheek, fold it, up the center crease, set that aside. Rinsing washcloth, wring it out, up the center crease, cheek, up the center crease, set it aside. Same towel, pat dry. Now, while they're on their side, we're going to change that chucks one more time. So we have a clean butt now. We want a clean pad. So change that chucks one more time. And then after we've changed the chucks, we need them on their back in the center of the bed. We're going to clean up our environment. So everything goes in dirty linen, clean your basin, store it, take your gloves off, take the privacy blanket off, and pull the sheet. Do I want to touch this sheet that's going to go right up next to her face with those gloves? Think about where those gloves have been. Right? Do I want to touch this that's going to go here with those gloves? So let's take our gloves off first. And then we can pull the sheet up and take the blanket away. And then we'll do our closing. Thank you very much, Miss Jones. This goes in the hamper. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Everything good? Here's your call light. Bed's in low position. Environment's clean. Open curtain. Wash my hands. My skill is done. Okay. You know all the steps to this. There is nothing. I did not teach you a new thing. I did not teach you a new thing. It's just repurposing those steps. Yeah, it seems like a lot of steps, and here they are, right? It seems like a lot of steps, but you know all of them, right? We're going to follow the care plan. We're going to do our opening. We definitely need gloves for this, spoiler alert. We're going to use linen, so linen rules apply. We need a barrier to put all of them on. You need a privacy blanket to cover the patient. We're going to make sure they're in the middle of the bed when we turn them. Washing rules, well, we know all of those. We haven't even got to the skill yet. Look at everything that we've got checked off. We haven't even got to the skill yet. We are going to clean our basin the way we clean all basins. And now we're going to get to the skill, but there's so few steps that are about the skill. Do you guys see that? Like most of the skills that we've learned in the last 2 days, it's almost all black in the middle. This, yeah, you've only got 4. Everything else is stuff we know.
Why does it say clean the basin before the skill?
Oh, I just did that. Yeah, you're right. But I'm just going by the shortcut
Like,
steps.
it'd be
Yeah.
clean, right? You just fill it up
Yes.
with
Yeah.
water.
Yeah.
Okay.
Yeah. No, I'm just going, I really should put this more up here, but the problem is that the steps for the skill are kind of all over, like scattered through here. Okay. And then we, of course, end our skill with our closing the same way we end everything else. This care plan is only for this person, not for these. Every care plan is going to be different because every patient is different. All right, Jake, show them Peri-Care. Hello, Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to perform Peri-Care. Is that okay? I'm going to close your curtain, wash my hands, get my supplies. I'll be right back. After washing my hands, I'll get my clean supplies. We're going to place the supplies on an overbed table, and we'll start with a barrier on the table, making sure that the absorbent side is facing up to catch any water spills. This gives us a clean place to put our clean supplies. For this skill, we're going to need 2 chucks. We'll need a towel, 4 washcloths, 1, 2, 3, 4, and a privacy blanket. We'll go to the patient area. And now I'm going to get a basin and soap. We'll place this on the overbed table. And I need a set of gloves. Now I'll go fill the basin. Miss Jones, I'm going to go get some water. I'll be right back. To fill the basin, I'm going to use a paper towel to turn the faucet on because my hands are clean. I'll use my wrist to feel the water temperature. It should feel warm, not hot, not cold, just warm. And we'll fill the basin about 1/4 of the way full. Mrs. Jones, would you like to check the water temperature? It's good? Wonderful. I'm going to set this on the barrier. And this is a privacy blanket. This is going to keep you warm and protect your privacy while we do this skill. I'm just going to stretch it out over your sheet. And then I'll pull the sheet down underneath the privacy blanket. And we're going to pull the sheet down to about your knees. Now, I'm going to prepare my chucks. I'll unfold them, hold them up lengthwise, and I'm going to roll it toward me. Clean rolls toward me. All the way to the end. I'll put this on the barrier and do the same with the second. I'm going to open it up. Hold it up lengthwise with the absorbent side facing me and roll it all the way to the end. Clean rolls toward me. We'll set that on the barrier as well. Now I can put my gloves on. I'm going to place the washcloth in the basin to warm. I'll take one of the chucks that's rolled. I'm going to lay it up next to the patient under the soiled chucks. And Miss Jones, if I can have you scoot toward me, please. And we're going to roll up on your right side so I can change the chucks under you. I'll help you roll. Okay, now that you're on your side, I'm going to take the soiled chucks and roll it in. Clean rolls toward me, dirty rolls away. I want to roll it so that the absorbent side is on the inside and the waterproof side is facing up. I'm only going to touch the waterproof side, and I'm going to tuck it underneath the patient's hip. I'll unroll the clean chucks and tuck it underneath the patient's bottom area, under the dirty. Okay, Miss Jones, come on back. Thank you. And if you can scoot to the middle of the bed. Thank you. I'm going to go around to the other side. Go ahead and scoot toward me. Thank you. And roll up on your left side. 1, 2, 3. And I will remove that chucks, the soiled one, and smooth out the clean. We'll fold this up and we're going to throw this directly into the trash can. Okay, Ms. Jones, can you scoot back to the center of the bed, please? Thank you. I'm going to expose you now. I'll make this as brief as possible. Please let me know if you're uncomfortable in any way. I'm going to roll the gown inside the privacy blanket, and this will expose the peri area. And then I'm going to use a towel over the upper thighs to keep all of that area dry. Now we're ready to clean. I'll take the first washcloth, wring it out, and soap 5 corners. We're going to use the leaves method, meaning the free ends are at the top of the diamond shape. I'll spray the first leaf, fold it over, spray the second leaf, fold it over, spray the third leaf, fold it over, spray the fourth leaf, fold it over, and the back. I'll set that aside. Now I'm going to clean the peri area. I'll hold the washcloth in my hand in a diamond shape, tucking in the 2 side corners, making sure I have control over the leaves and they're at the top so that we can minimize cross-contamination. Okay, Ms. Jones, I'm going to start cleaning you now. I have to hold you open just a little bit, but let me know if it gets uncomfortable. So I'll take the heel of my hand at the top of the peri area, retract slightly, and spread her open a little bit. And I'm going to clean right down the inside middle, top to bottom, one direction only. Once I reach the bottom, we'll move away and fold that leaf over. I'm going to clean the outside peri area, top to bottom. Fold that leaf over. The other side, top to bottom, making sure I don't ever move back up. Fold that leaf over. The fourth leaf will go right down that skin fold, the crease between the thigh and the groin. We'll fold that over, and then we'll clean this skin fold, top to bottom, and we'll set that aside. Whatever we wash, we rinse. So I'll wring out my washcloth using that same leaves method, tucking in the two side corners. I'm going to retract the labia and clean top to bottom. Down the center, fold that leaf over. The second leaf will clean the outside of the peri area, top to bottom. And then we're going to fold that leaf over. The third leaf will clean the outside of the peri area on this side, top to bottom. I'll fold that leaf over. The fourth leaf will clean the crease, top to bottom. I'll fold that leaf over, and then we're going to clean this crease, top to bottom. And now we'll dry. Okay, Miss Jones, I'm just going to unroll your privacy blanket, putting the gown back over your legs, and I'm going to ask you to scoot toward me and roll you on your side so I can clean your back side. 1, 2, 3, and we're going to roll up. 1, 2, 3. We'll expose your back side, and the evaluator will hold the mannequin in place for this process. So now I can clean the back side. I'm going to wring the washcloth out. And this time, we're going to soap 4 leaves. So 1, we'll fold that over. 2, fold that over. 3, fold that over. 4, set the soap aside. I'm going to start at the anal opening and move up the crease. Just like that. We'll fold that leaf over. I'm going to clean 1 buttocks. We're going to fold that leaf over, clean the other buttocks. We'll fold that leaf over, and then once more up the crease. We'll set this washcloth aside. Whatever we wash, we rinse. So I'll wring that washcloth out really well. I'm going to hold it in that leaves shape. I'm going to rinse right up the center crease. Fold that leaf over. We'll rinse 1 buttocks. Fold that leaf over, rinse the other buttocks. Fold that leaf over, and then once more up the center crease. Now we'll dry those areas. So starting at the anal opening, we'll dry all of those areas. We'll set that aside. Now I'm going to take the new chucks, place it under the one that's on the bed, and we're going to roll this one toward the patient and tuck it under her hip, and unroll the new one and tuck it under the soil. Okay, Miss Jones, come on back onto your back, please. Thank you, and then scoot to the middle, please. And I'm going to go around and remove that soiled chucks. Go ahead and scoot toward me. And then we're going to roll up on your side, 1, 2, 3. So I'll remove that soiled chucks and smooth out the new one. Come on back onto your back and then scoot to the middle of the bed, please. Thank you. This will be thrown away. Okay, Miss Jones, you're covered. You're in the center of the bed. I'm going to go put your dirty linens away and clean the basin. I'll be right back. These items will go in dirty linen hamper. And I'll clean the basin the same way we clean all basins. We're going to dispose of the water into the sink. Rinse the basin. Dispose of the rinse water into the sink, set it down, disinfect it per facility policy. Use a paper towel to pick it up, paper towel to dry the inside. Throw that away. Paper towel to dry the outside. Throw that away. And one for the drawer. On the way, we'll pick up the soap, place it in the basin, use the paper towel to open the middle drawer, pick up the lotion and put it in the basin, and then store the basin in the drawer. We'll close it with a paper towel and then throw those paper towels away. We'll dispose of the barrier that's on the table. And then remove my gloves. Okay, Ms. Jones, I'm going to pull your privacy blanket up and put your sheet back in place. We'll make sure that the patient is covered and that we roll the privacy blanket up in a ball as we remove it from the patient. I want to adjust the sheet for neatness and appearance. And I'm going to go place this in dirty linen. Okay, Ms. Jones, are you comfortable? Is there anything else I can get for you while I'm here? Would you like a magazine? No? Okay, your environment is clean. Here's your call light. If you need anything at all, just press that red button and somebody will be happy to help you. Your bed is in the low position. I'm going to open your privacy curtain and go wash my hands. We'll return this table to storage before we go, leaving our area clean. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. All right, any questions? Yes.
Are you left-handed?
I am ambidextrous.
Oh.
I can use both. Yep, growing up in school, I routinely wrote with both hands. Yeah, I don't really use, I don't write, I don't write with my left hand much anymore because, you know, it's just more practical to pick one. But yes, I have one left-handed child and 2 or 3 right-handed children.
So whenever you open to grab this barrier, you didn't use a napkin or have the glove.
You don't have to open a drawer. You do not need a barrier to at the end of the skill return something to storage. You do. Yeah. Yeah. That's just like washing your hands. To turn the faucet on, you don't need a barrier, but you do at the end. Okay. Good. Questions on this? Questions on this? The practice kit has all the items that you need to be able to practice. It has the basins, it has the gait belt, it has the triangular graduate container, it has a food tray, it has the soap and the lotion. It has everything you need to be able to practice. And your homework over the weekend is going to be chapters 8 and 9. 8 is on nutrition. It's a short chapter, but it's dense. You guys do there. I think there's 8 different diets in there. You do need to understand that different diets are used for different health conditions. And you will have a question on the state exam about what kind of snack to offer, or you're giving trays, you know, something about diet. So you have to have some understanding. Chapter 9 is on rehabilitation and restoration. It's a pretty easy chapter, not a whole lot of dense material there, but it does cover patient positions, which you do need to know. Okay, so that'll be your homework, but neither one of them are really long. They're not like the beginning of the book where it was like, oh my gosh, it's going to take forever to get through. The chapters are a little bit shorter toward the end. All right, you should be receiving your wrap-up emails. Hopefully that's the case. And I already passed out, or Jake and I already passed out your review sheets for today. Go ahead. Go ahead. Anybody have any last questions for me before we dismiss? Yes.
Am I allowed to grab class 7?
Sure, they're right there by the door. Just grab what you need. Just grab what you need.
Do everything I can to be here, but
All right, so we're going to go ahead and sign off of online. Thank you so much for tuning in. We really appreciate it. We will be back on Monday for class 7. Wednesday ends this class session for class 8. Make sure that you mark your calendars, and we start at 9. We'll see you next time. Until then, happy caregiving. Bye.